Good morning. Thank you for joining us today for the 2022 Ask Educator Conference, Educating Childhood Cancer Patients and Survivors. We provide this conference in partnership with the Virginia Department of Health. I'm Susan Lindsay, Program Director for Ask Childhood Cancer Foundation. Ask was started over 45 years ago by a group of parents in the waiting room of what was then called Medical College of Virginia, or MCV. Today, Ask is Virginia's most comprehensive provider of support services for childhood cancer patients and their families. One of the ways Ask helps families is through direct educational support. Cancer treatment can disrupt school, but it also affects physical development, social-emotional development, and cognitive development. And these late effects can greatly impact academic success. It's worth noting that while our focus is on childhood cancer, the information and tools that you will learn today can be applied to children in your school who have other chronic health conditions as well, other than cancer. Over the course of the conference, you will learn about late effects of treatment, how education plans like 504 and IEP can help, and how to use the Ask Childhood Cancer Education Toolkit. You will learn about challenges specific to teens and young adults as they transition into high school, but also into adulthood. You will learn how to identify and assist patients and siblings struggling with the emotional impact of cancer. You will learn how grief and loss might appear in your classroom or school, even when treatment is successful. And finally, you will hear from parents and an adult survivor about their own experience navigating educational needs. Thank you for your partnership and commitment to providing support to these unique needs of childhood cancer patients, survivors, and also siblings. Together, we are making life better for kids with cancer. It is my pleasure to introduce our first presenter, Dr. Madhu Gowda, pediatric hematologist-oncologist with Children's Hospital of Richmond at VCU, where he cares for both patients and survivors. Dr. Gowda will provide an overview of pediatric cancer, explaining the frequency of diagnosis, treatment experience, and the physical limitations of childhood cancer patients and survivors. If you have questions at any point during the conference, please feel free to type them into the chat, and we will get to as many as possible. Let's get started.
Hi, good morning. I'm Dr. Madhu Gowda. I'm one of the pediatric hematologist and oncologist at the Children's Hospital of Richmond. And welcome to this talk up for educators to learn about childhood cancer, complications, and how we can help them go through life during the cancer treatment as well as moving forward after cancer. This is a little bit of a dense talk, so get ready with all your coffees for the next half an hour to 45 minutes. I'll try to give you a brief overview of what childhood cancer is all about. Mainly, I'll be focusing on these considerations here. We'll go through some of the cancer numbers, how many and how the outcomes are. We will look at childhood cancers, how they present to the family or to the parents, or even in the medical setting. We'll talk very briefly about some treatment considerations, giving a very, very broad overview of what all it takes to treat one particular malignancy. We will talk about some of the complications of treatment and then going on to the long-term effects. The last part of it, which is about school reintegration and help at school, my colleagues and our educational consultant, launch coordinator, they will all pick up on most of these things, and I will be giving an overview of these as we go through. To start off with, I know that you got a copy of my slides beforehand, and the data there was a little bit outdated. I think I had the 2017, 2018 data there. This is the newer ones from 2020 that I could find. If we look through that, it does talk about the US population. We are about 331 million as of 2020. And if we look at the number of new cases of cancer that are diagnosed across the country, we have about 1.8 million This is including children and adults. And when you look at the right side of the table at the top, the estimated number of people that do not make it through is nearly about 800,000. So nearly 1 in 180 people develop cancer, and a third of them don't survive. This is across the board through the country. I broke it down a little bit into the Virginia state population, and when we look through that, we pretty much follow the national trend, in which for about 8 million people that we have, 47,000 people are diagnosed with cancer every year, and that's roughly about 1 in 180 people. And our survival, the last table that you see there, the 15,220 is the estimated number of deaths in 2020 because of cancer. So which again translate to about a third of them not surviving through this malignancy. And this compares or contrasts to the number of children and how that works for them. If we look at that, again, this data is a little bit old, 2017-18 data. I couldn't get really the recent data on these numbers, but more or less, I don't think much has changed in that time. For about 60 million children less than 14 years old, and about 12 million of them between the 15 to 17 year age group, which is what we take as the childhood cancer group between 0 to somewhere around 18 to 19 is what we take as childhood cancer numbers. So the number of new cancer diagnoses was nearly about 10,000. So for a 60,000 population, 72 million population, it translates to about 1 in 6,000 that will develop cancer, and about 1 in 4,500 in the 15 to the 19 year age group, which means that as they get older, the chances of developing a cancer becomes a little bit more frequent. So just to contrast that, we were looking at in the previous slide, about a 1 in 180 people developing cancer. Here for children, we are looking at about 1 in 6,000 of them. When we look at the number of people that do survive, that there's about 89% of them will survive. Again, just contrasting to the previous slide, where a third of the overall or the most of the adult population do not survive malignancies. In children, nearly 89-90% of them will survive. So that is something of a good thing that we have to consider, even with all the bad news there. So when we cross compare this one, I don't know if your slides are in black and white, but the big group of blue is the total population, and that small sliver on top, which is more in orange, that is the one that represents the number of children. So you can see that it's a very small fraction compared to the bigger population at large. Over the years, definitely cancer, as the treatment for cancer has gotten better, and we are seeing much better survival rates. As I said, this is a list of pediatric cancers and how the survival has changed from somewhere in the 1960s to the early 2000s. We can see that for most of those conditions in the bottom, we have already crossed the 80 plus mark for survival. There's still a couple of places like in the middle where there's a condition called neuroblastoma, which is still somewhere in about the 50% range. And we have not made much of a dent in that condition, but the rest of them we can see is nearly in the 80% or somewhere in the 75 to 80% that we are crossing. Again, just to go in a historical perspective, as I said, treatments changed and our survivals changed over a matter of time. Somewhere in the 1950s, if you look at the left side, the bottommost curve that is there, the single agent in the 1950s, and the bottom line talks about the number of years. At 1 year, when we were using single agents, all those patients would pass, as in we did not have any survival at all using single agents in the 1950s. Somewhere in the 1960s, we started doing combination therapies, which is adding on multiple agents. That helped for some time. It helped to prolong life, but did not prolong the survival, because as you can see, by somewhere around about 4 years from diagnosis, all of those patients did pass too. So we had to intensify the treatment, and the next phase that started off in the leukemia treatment was treating the CNS, or the central nervous system, which is involving your brain and the fluid around the brain. So we had to get chemotherapy or treatment into that space. That's where that CNS prophylaxis started in the 1970s. And when we started seeing long-term survival, that is when we first started seeing that children could survive leukemia in the long term. And of course, we made more intensifications into treatments and our survival got better and better. But of course, that does come with a cost. The CNS treatment, as I mentioned, the one that we are using to treat the central nervous system, is one of the things that is going to affect cognition, that is going to affect their performance in school. And that is one of the things we'll have to come back to later on in the slides to see how we can help them through. So the good news is childhood cancer is very rare, and the majority of these children will survive this cancer. Going on to the number of cases, it's a little bit of a different track that we are going into now. The incidence of cancer overall across the country is slowly coming down. Not great, but it is overall, we can see that there is a trend of things getting better for the general population at large. But when you break it down to the people that are less than 20 years old, if you can look at the top curve there, we can see that there is the incidence of cancer is actually slowly going up by about 0.6% every year. So overall numbers are going down, but in the younger group, there's a trend towards a small increase in the number of cancers. This talks about the causes of death. Up on the left side, the top part of it, you can see that cancer is the second most common cause of death in the overall population. Now, that is including children and adults. If you look at that, the heart disease is the number 1 cause of death, cancer is the number 2 cause of death, and it's more or less nearly as much as the heart disease condition is. The right side, the bottom part of the graph that you see, you can see that is for children, and here cancer is the third most common cause of death. The first and second, as you can see, is either motor vehicle accidents or firearm related injuries, which is very unfortunate, and malignant neoplasms is the third common cause of death in the younger population. So that's the bad news, is that the cancer deaths constitute about 10% of the overall pediatric deaths. It's the third most common cause of death in children. But when you look at disease-related causes, this is the first most common cause of death from disease. And when we talk about people that have been treated and getting into survivorship, survivors tend to have significant side effects. So those were your what we call epidemiological data about how the numbers are across the country and over time. So here, this is just brief overview of what are all the different kinds of cancers we see in the younger kids, children less than 15 years of age, leukemias, brain tumors, lymphomas, neuroblastomas. So it lists out all the different conditions that we see. And a nice pictorial of that is out here. You can see that the leukemias, lymphomas constitutes the bulk of the diagnosis. The second most common cause is the brain tumors, and the rest of the other ones follow below them. Do we know what causes cancer in children? Unfortunately, there's not many things that we can pick up and point out to. There are some things that we know, which is if you have a genetic predisposition to that, if you have been exposed to radiation, if you have been exposed to some toxins, or for some reason they have a bone marrow failure syndrome, which usually goes again hand in hand with genetic problems. Some immunodeficiencies or viral infections have also been associated with causing cancers. And for a clinical diagnosis, it's usually incidental, it's unexpected. The child is usually doing well and all of a sudden starts having some vague symptoms and signs, and within a matter of days, they are diagnosed with a malignancy. So there's not too much of a lead time between when it starts and when it manifests. It starts, it manifests very quickly, and usually it's picked up very quickly. So prevention of that is a little bit difficult. And like we talk about doing mammograms for screening breast cancer or colonoscopies to screen for colon cancer in the adults, in pediatrics, there's not much that we can do to screen beforehand. So early diagnosis usually not possible. When I say early diagnosis, yes, the diagnosis happens as soon as they manifest their symptoms, but usually before that, it's very difficult to pick up on this. Most of the complaints are usually very commonplace. For example, a child comes with ear drainage, which looks very much like an ear infection. Some of them may have fevers, aches and pains, just having headaches. You wouldn't think too much of that, but these are all very common complaints, but can be a marker or can be a sign of them developing some kind of a malignancy. So we do have to keep a little bit of a close consideration for any of these things if they're not falling within the realm of general pediatric symptoms. So the next few slides looks at a couple of manifestations. Now these are lymph nodes which all of us have in our bodies, and anywhere along this area, if there is a swelling and the swelling is getting bigger and not going down with time, those are things that we get worried about, and those are the things that bring the child to the attention of the medical practitioner. Some of these things can be very subtle, like skin changes. You can see up on top what we call as a blueberry muffin baby, which means they have those black spots all over the face. And some of these are malignant cells in the skin. The one in the bottom you can see just has discoloration below the eye. You could say that it was probably some kind of a trauma, but some of the malignancies can manifest like this. This is a classic sign we call as the raccoon eyes, which is something that we see in patients with neuroblastoma. Now this one, you can see that on one side the pupil is nice and red, and on the other side it is white. And yes, we want it to be nice and red with a good blood flow. If you are seeing something opaque, white, that is something of concern for a retinoblastoma or a malignancy in the eye. Some skin changes like this are predispositions to develop malignancies. So if there's a lot of these kind of skin blemishes, those are also things that bring them to the attention of the medical practitioner. An unequal size in the limbs. On the left side, the limb is normal in size. On the right side, there looks like there is a swelling. So any unusual sizes, something to get worried about. So switching from diagnosis, we go to principles of therapy. Of course, it's not going to be a medical talk about all the different medicines that we use, but the three big things we have to think of is it has to be multicentric. It has to be multidisciplinary, and we need a lot of supportive care to be able to take care of these children. To start with the multicenter, what does multicenter mean? Do they have to go to another hospital? Not really, but the treatments have to come from different hospitals, different medical centers, different practitioners. The condition is so rare that one provider will definitely not see all the manifestations in their lifetime. So we do have to collaborate with other centers to learn about how did this child manifest in your center and how did you handle that. So that's where these cooperative groups come in. And these cooperative groups not just share information in terms of diagnosis and treatment, but they can pool their information together in terms of the biology studies, as in what different blood work, what blood test did you have and what blood test did we have. Is there some kind of a correlation between those kind of blood tests that we have done, or even cell banks, trying to get some tumor cells and trying to bank them for trials that we can use later on. Clinical trials account for more than 90% of pediatric patient cancer care, again because we do need the collective wisdom of all the oncologists in the country. And in that, we use this group called the Children's Oncology Group, which is the world's largest organization for pediatric cancer research as well as for the clinical trials and treatments. We have learned, as I was showing you in the earlier slide, where in the 1950s, using single agents, we were not able to get much survival, but as we intensified treatment, our survivals went much better. And the reason that it happened was because each generation, each decade, there was a clinical trial that looked at it, shared that information, and built upon those results. And that is what the Children's Oncology Group over a matter of time has done. It has centers in the US, Canada, and other countries around the world. And there are many experts that put their suggestions, and they all work together in developing these clinical trials. And we can see that more than 90% diagnosed with cancer each year are cared for at a Children's Oncology Group site. So being in a clinical trial will give us access to the state-of-the-art therapies. And in addition to the Children's Oncology Group, we have something for the brain tumors called the Pediatric Brain Tumor Consortium. For neuroblastoma, there is something called the New Approaches to Neuroblastoma Therapy. And some of the bigger centers like St. Jude's, Memorial Sloan Kettering, MD Anderson, or Dana-Farber, they all have their own institutional protocols also. And we do share that information, we do share those protocols to be able to treat our children in any center that they come to. So that is what I meant by multi-center treatment, is we do have to borrow on the expertise, the protocols, the treatment parameters from multiple places to be able to provide care for these children in our center. The second one that we look at is multidisciplinary. Again, just like I was talking about, it is not that one provider is an expert on everything. We need multiple specialists to take care of them. And when I look at this is just the medical part of it, because the non-medical group is a much larger group that I'll come back to. When we look at this, we do need our oncologists who write the chemotherapy part of it, the surgeons to do the surgery, the radiation doctors to be able to give the radiation. Immunologists are necessary now because many of the treatments are going in for what we call as immune therapy, which is modulating the body's own immune response to be able to fight against these malignancies. We need pharmacists. The medicines are getting more complex, and we need to be able to understand how is one going to interact with another medication, and is it a good thing to put the two together or not a good thing? So we do need our pharmacists to be able to help us through this. And of course, as the children are going through treatment, we need people from the pain surveys, symptom management groups, and they all together help take care of these children. So going to this part where I mentioned that we do need multidisciplinary care, let us look at some examples. For example, leukemia. Leukemia is what we call as blood cancer, and it lasts for about 3 years. The treatment lasts for about 3 years. The more intense part for somewhere around 6 to 8 months, and then we call what's called as a maintenance for about 2+ years. It includes chemotherapy. Some of them may need to get radiation, and some of them may even need to get a bone marrow transplant. The second group, the brain tumor patients, the treatment lasts for anywhere between 6 months to a year, and depending on whether we categorize them as low risk or high risk, we have to modify their treatment. And brain tumors are notorious for recurrences. Here we need to have the surgeon, we need to have radiation, we need to have chemotherapy, and we sometimes even have to do a bone marrow transplant. Even though the tumor is not in the bone marrow, it helps us to augment the therapy and improve survivals. Now, this is the one that I mentioned even in the past slide called neuroblastoma, where we have not made too much of a dent in treatment. We are somewhere around 50-55% in the overall survival. The treatment can last for about a year to year and a half. Here we are pretty much using every mode of treatment that we know about. We are using chemotherapy, we are using surgery, we are undertaking bone marrow transplants for them. They get radiation, they follow that up with immunotherapy. There are some agents called differentiating agents. We use that as a backup to keep them in maintenance and prevent some of these malignancies from coming back. So you can see that nearly every mode of treatment is being thrown at this condition now. In the other ones, like your bone tumors or in organ tumors, treatments can last 6 months to a year, and we do use chemotherapy, surgery, radiation. So essentially, we are using multiple disciplines, multiple modes of treatment for each of these conditions. So just as a very quick look, complications during treatment. As we are doing all this, you can see that they are at very high risk for infection, and the infection can range anywhere from bloodstream infections to infections of the gut, and they can have problems with their nervous system, like we mentioned earlier on, is seizures, having problems with processing, and having problems with their memories. All of those are the complications that can come up during the treatment. So that is where, for those kind of treatments, is where we need the pain surveys, the symptom management people, along with other specialists to work with us. The next piece of it is what I've mentioned as supportive care. And for supportive care, in addition to the medical, not that the medical professionals are not supporting them, but that's a very, what you call, a different set of help that we can provide. And the supportive care team has a much more bigger role. You can see that this is a big group of people ranging right from nursing, our social worker, the child life specialist, occupational therapy and physical therapy people, the nutritionist, our psychology colleagues, our chaplain, and of course our educational consultants. All of these are necessary to get this child through the treatment and beyond. So going away from the medical complications, the non-medical considerations, we do have to note that it is an emotionally devastating diagnosis, which affects the family, friends, and the whole environment of the child. There's financial hardships, and taking care of this takes a lot of sensitivity and time. In this, I just want to point out one of the things, which is the financial hardship part of it. As we are talking through today, I think there are different providers who will be talking about the psychological part of help, the school part of help. And I'm just mentioning the financial hardship part of it in a couple of slides here. This talks about rough cost of treatment. Of course, insurance matters much, but there's definitely still going to be what we call as your co-pays, deductibles, and all those things. And if you look at it, the neuroblastoma, again, I come back to that, costs more than $2 million to take them through this treatment, where we are using nearly every mode of treatment. A patient that is getting an allogenic transplant can run up to $1 million. And even though your insurance and all your supportive agencies provide the financial support, we can see that 1 in 5 children who are getting a new diagnosis of childhood cancer are already living in poverty. And on top of that, when we add on these costs, those who are not poor became poor during treatment for their child's cancer. 1 in 4 families lost more than 40% of their annual household income because of childcare costs being needed to take them from the clinics to the clinics to home, and during admissions, there's a lot of time lost from work. And 1 in 3 families also face work disruptions, like having to quit or change. This is what is called as a household material hardship. And even though it was reported at diagnosis and when the children are going through treatment, when we looked at it off treatment, children are now about a year off treatment, nearly about a third of the families still reported that they were going through this hardship. That goes on to say that the end of treatment is not the end of all the problems. We continue to have some problems that we have to deal with or face with from even after the end of treatment. And that's where we come into pediatric cancer survivorship. Just want to take a brief break here and see if there are any questions about the things that we have covered so far, which is the numbers that we talked about, the diagnosis, the treatment considerations that we talked about, before I move on to the post-treatment or survivorship part. I hope I've not put everybody to sleep here. So moving on, then we talk about pediatric cancer survivorship. Children survive their malignancies and go on to become adults, go on to become productive members of the community, and we continue to follow them up as they're going through that. We know that there are more than 400,000 cancer survivors, and there are nearly about 350,000 of them are adult survivors of childhood cancer. Nearly 1 in 640 adults between the ages of 18 to 45 is a childhood cancer survivor. And again, this is old data, 2014 data, and sorry, I could not find the newest data as I was looking through that, but I'm sure I think our other speakers should have some of the later data. Like we talked about, cancer care is a two-edged sword because we do have a good bit of cure, but that cure comes with side effects. We did have this group called the Childhood Cancer Survivor Study, where more than 10,000 adult survivors were followed for many years from the end of the treatment, and they were compared to their own siblings to see how they were differing. When we looked at these survivors, 2/3 of them had at least one chronic health problem that they carried on for many years. A quarter of them had a condition that we would categorize as a severe condition, and a quarter of these had 3 or more health problems. So when we look at chronic conditions and compare the survivors and siblings, the survivors were nearly 3 times as at a higher risk to develop a chronic condition than their own siblings. And when we look at the severe conditions, they were nearly 8 times as likely to have a severe condition compared to their own siblings. Because of this, we need to continue to follow up even after the end of treatment. So we do need to develop a systematic plan for lifelong screening and for surveillance and to prevent any of these late side effects that may happen. We look into what the cancer treatment they got, what was this genetic predisposition or any genetic information that we have from their treatment, what lifestyles that they are following from the end at the end of treatment, and any comorbid conditions that they may come up. With that, we come up with some kind of a what we call as a risk-based follow-up plan, and the plan is that to continue to follow up with them for life. And when we talked about the treatment modalities, on the right side of this, we can see the treatment modalities going from chemotherapy to specific medications called methotrexate or steroids. And on the left side, we can see what are some of the complications that they correlate to. In the second one, you can see that those who have gotten cranial radiation, which is radiation to the head, they have problems with intellectual dysfunction. The same thing can cause neurological problems. If we go down, the last one is secondary neoplasms, which means secondary cancers. So anything like radiation, cyclophosphamide, or cytoxin, etoposide, all of those things can predispose these children to develop a second cancer much, much, much down the line. And based on these potential late effects, these are some of the recommendations of what we need to evaluate them for. For example, if we go all the way down to the bottom, secondary malignancies. So developing a second cancer is a possibility. So we have to be looking at a history and physical on them every year. We need to be looking at the CBCC, which is a blood count marker, a skin exam, because melanomas or skin cancers are pretty common. So those are things that we absolutely need to be doing on these children at least once a year for life. If we look at the third from the bottom, the cardiac effect, there are some medicines that can affect the heart. And when we look at the overall group of survivors, we see that nearly about 45 to 50% of the cancer survivors will have some problem with their heart. So we need to be following up with them with periodic echocardiograms, or sometimes even what we call as MOGA scans, which is a nuclear medicine scan, to look at heart functions. When we looked at a young adult population and asked them what are all the problems that you are facing, you can see that it went all the way from developing diabetes to as much as having problems with difficulty to have children. In the third part of it, you can say that there is difficulties with learning, memory. So the side effects run the whole gamut whole gamut of involving each and every organ system. The next couple of slides looks at the survivorship population and compares them with the siblings. If we can look at that, the presence of any health problem, we call it as a grade 1 to 4, which is mild to moderate. 3 to 4 is more of the severe conditions. 1 to 4, if you look at all the grades of side effects, the siblings had somewhere around a 36% of having those kind of health problems. Again, these are not unique health problems. For example, hypertension can happen to anybody, and even a person that has not gone through chemotherapy or cancer treatment can develop hypertension. So that is what we would call as the sibling group, which is, let us say, 36% of them had it. But in the survivor population, you can see that 62% of them had that problem, which means that they are at a higher risk than the general population to develop these side effects. The grade 3-4, which is your severe side effects, if you look at it, the siblings, which is your control population, may have about 5 to 6% chance of developing those severe complications or severe manifestations of their health conditions. In the survivorship population, that was nearly about 27% of them, nearly somewhere around 6 to 7 times higher than the siblings. As we take them through into their adult life, we saw that unemployment was higher among survivors who had particularly CNS tumors or brain tumors. If you look at that straight dotted line on the left side, which is at 1, that is your reference range, or where the siblings are marked at. And on to the right side of it is where we see the relative risk of being unemployed. So if, for example, all survivors, it is somewhere around 6% more than the siblings to be unemployed. In the second group, you can see the central nervous system, which is the people that had brain tumor. They are somewhere around 12 to 15% higher than their siblings to be unemployed. When we look at cognitive problems, this is where it comes down to the crux of the educators, which is having problems with their memory processing and school issues. We saw that survivors reported more problems than their siblings. Again, we can compare that right there. In concentration, if 6% of the siblings were having a problem, nearly 12% of the survivors were having it, nearly double of that. Slow working speed was one of the concerns. Memory issues were one of the concerns. And when you look at any cognitive problem for that matter, they were nearly about twice that of the siblings to have these issues. Now, the survivors also reported utilizing more special education services, which is a good thing, which tells us that what we are doing is meaningful, because yes, we are providing these special education services, and our educational consultant will be talking to you a lot more about that. Is they need the services, they reported utilizing more services, which means they're getting those services to help them move along. So what causes some of these neuropsychological effects? As I mentioned earlier on, coming back to that, which is CNS therapy, the one that helped us to get into survival was to be able to treat the brain and the fluid around the brain, and putting chemotherapy into those areas is what helped us to cure some of these malignancies. But of course, when we started putting treatment into those areas, that is what caused some of these neuropsychological side effects. The medications that were given, some of them, because during treatment, can have a stroke or a bleed into their brain. Those are some of the things. And of course, we can't discount the psychosocial factors that go along with that, which is the impact it has on their emotional well-being is also going to affect this. So just a couple of brief slides. I won't go much into detail on the school issues and re-entry, because since our educational consultant and our launch coordinator will talk a little bit more on this one, what we are looking at is, yes, there will be school issues because of all these things. When do they re-enter back into school? When they're getting into their maintenance treatment, can they come back? Or do we want them to finish up all the treatment before they come back? If they do come back, how are we going to deal with some of these side effects like having fevers, having bleeding episodes? And the big thing is they do come with central lines, which means they have implanted lines that we use to give chemotherapy. And if they're coming back into the school environment with this, what's the risk and how should we help them through that? Of course, any child that is going through treatment or even for many months afterwards is going to be very fatigued. There is going to be deconditioning. And how do we help them along with that? And of course, the school performance is also something that we need to worry about. It's not just being in the class. How are they going to perform with their educational activities? So some of the recommendations that the Children's Oncology Group, that's a group that we work has to provide the treatment, they also give recommendations on what we need to be doing to help children get back to school. Some of the brief things I mentioned here, as I mentioned, our educational consultant will talk a little more on those, but we had to look at making it easier for these children to reintegrate back into the school environment. So there's a cost of cure. There are long-term side effects, and it can impact any of the organ systems of the body. There's going to be a lot of psychosocial impact. There is definitely a risk of secondary malignancies. And as we talked about, not just during that time, later on as they're getting into employment, there is going to be problems with getting into jobs. And of course, being employed also ties into their insurance. And one of the things I don't mention here is some of the difficulties in getting a driver's license and being able to become independent, I think is also something that would factor into that. So there is a cost for the cure that we have. But finally, it is all worth it. It's all worth seeing these children be done with their treatment and move on with their lives. That brings me to the end of what I had to talk to you about today. If there's any questions, I can take them now.
Dr. Gowda, Tracy Sanderson would like to know more about St. Jude's funding model. She asked, is there adequate funding sources to help with financial hardships like St. Jude's? And then can young adults continue to be followed at places like St. Jude's and have those expenses covered? If you could maybe explain, I think a lot of people have the perception that if children just go to St. Jude's, they'll have all their expenses covered. And can you explain why they might not go there?
Okay. And so I think it goes to St. Jude's as a different model from the other medical centers or the cancer centers. St. Jude's is a big clinical research center. I can't talk too much in detail because I don't know the ins and outs of their financial model. But what we do know is that the clinical care that the children get there is free because St. Jude's has a big fundraising mechanism, and they try to focus more on clinical research, developing new protocols, and being able to provide that. And as part of the clinical trial, children do get free care. About the question about can young adults continue to be followed at St. Jude's, some of the data that I mentioned there came from something called SJ Life, which is St. Jude's for Life, which is a program that they have where survivors can continue to go there to be seen for their survivorship care. Now, what I do not know is what is their upper limit of age. Is it somewhere around 25 where they can't continue to go there, or 35? I'm not 100% sure about that. But what we do have here at the Children's Hospital of Richmond, where we run the survivorship program, is we do not have an upper limit of age. Any child that is diagnosed before the age of 18, we continue to see them at least once a year or once in 2 years as a medical home that we provide. This is where you come if you have any questions that you want us to answer. Is there any concern that you have about something that's just not sounding right to you and you want to be checked out for that? Yes, we will always be able to provide that care here. I hope that answers your question there.
There are no more questions. Thank you, Dr. Gauda, for joining us this morning and giving us so much good information about childhood cancer. If any more questions come up after today's presentation, Dr. Gauda's contact information is on the presenter information page in your conference resource folder. If you didn't feel like you had enough time to answer the questions on the post-presentation survey, we will send you links to all the surveys after the conference is over, so don't panic. Our next presenter, Alma Morgan, is an invaluable resource for families when their children are returning to school after the diagnosis of cancer or another serious chronic illness. Alma is the educational consultant for Children's Hospital of Richmond at VCU and also the education coordinator with ASK. With over 35 years in education, Alma loves working with children, teens, and young adults. She believes that all children can be successful in the educational setting with the proper tools. Please welcome Alma Morgan.
Thank you, Denise, for such a nice introduction. Good morning to everyone, and happy Friday. It's a delight to be here today with 190 plus participants and fellow educators. Thank you for joining us, and thank you for wanting to make a difference for these children that we are talking about today. I often say that I have the best job in the world. I get to work with beautiful children and beautiful families. At the same time, I get to travel to schools throughout Virginia, working with professionals, you in the classroom, working with professionals who are making a difference in the nurturing and learning environment for all of our children. So hats off to each of you. I know we've been through the past 2 years, very challenging times, but stay with education, because as an educator myself, I feel that it is one of the greatest blessings that we could have, working with so many wonderful children and making a difference in their lives. So today I'm going to start with some good news. 87% of children diagnosed with cancer today will survive. That is so different than when I started at VCU Medical Center in the late 1980s, early 1990s. So many changes have occurred. We had 83% survival rate in 2008, 2014, and then 56% survival rate in 1975 to 1977. Based on these statistics, I was thinking back, and probably in 1988, when I started at VCU in the early 90s, we were probably up to 75% survivorship rate. At the same time, research over the past 30 years has improved. The treatment protocols have improved greatly. And I just want to give you 3 areas that I was thinking about these areas last night. One, when I first started working with children with childhood cancer, I noticed that their treatment protocols were sometimes 2.5, 3 years for a leukemia survivor or a student going through treatment for leukemia. So at that time, when I look back, they were out of school for that 2.5, 3 year period. Today, that has changed. We started finding that children were suffering from separation anxiety after 3 years. When it came time to go back to school, they were missing their parents. They had lost contact with friends, and they were depressed and very sad. So we started, as soon as their counts started to rise during their treatment, we started sending them back to school. So 6 to 12 months into treatment, even though they might have hair loss and still need lots of accommodations in the classroom setting, we are sending them back to school, and they're being much more successful. Another area was that in the early 90s, many of the children on chemotherapy, they were sick. They were very sick. We did not have the Zofran, which is an anti-nausea drug at that time, or it had just came out in the early 90s. And I know working with families, a lot of the parents said, I don't have the insurance to buy, and the drug is very expensive. So now we find that the medications have improved greatly and the children are feeling better. And the ones who are assigned homebound teachers, they are able to work with the homebound teacher. For elementary age, as you know, they get 5 hours a week, which is not very much, but still it's 5 hours a week of one-to-one instruction. And then for middle and high, 7 to 10 hours. So that really does make a difference, and we're finding that more and more children are feeling better and able to work with their homebound teachers. At the same time, also, our comprehensive educational plans that we offer today, they're better than ever before. In the 90s, I went to a couple of rural area schools, and they told me, we've never written a 504 plan before. We need your help. So now we have very, very comprehensive plans that are really making the difference for these children and providing the educational supports and accommodations that they need to be successful. Now, I hate to do this, but I have to share a little bad news with you. 95% of childhood cancer survivors will have at least one chronic late effect by age 45. And then 80% of childhood cancer survivors will have at least one serious disabling or life-threatening chronic health condition. That's why we have our survivorship clinic, where our survivors come to us, and some might come yearly, some might come more frequently. And we look at all their medical issues, we look at their cognitive issues, we look at how they're doing socially, and we're helping them to develop into being more independent individuals in society and finding that normalcy that we want for all of our patients. So what are the main chronic illnesses that we see? I would say the endocrine and problems, growth issues, cardiac issues, and then the cognitive problems. Who has these challenges? Well, 2 out of 3 survivors have at least one late effect. 1 out of 3 survivors has 2 or more late effects. And 1 out of 3 survivors has a late effect that affects quality of life and or mortality. So I'm going to further explain this a little bit more, because cure is not enough. Cancer therapy can cause late effects. And what are the late effects? What are late effects? They're consequences of treatment that persist after therapy has ended or that developed after the completion of therapy. And a lot of times these late effects can show up 2 to 5 years or even later after treatment. And every part of the body can be affected. What are cognitive late effects? And today that's what I'm going to talk about in the next few slides. Cognitive late effects refer to changes or difficulties in cognitive functioning. And when we're talking about cognitive functioning, we're talking about the cognitive domains of the brain. So what do? A lot of times we do neuropsych evaluations and testing, where it looks at these cognitive domains, verbal comprehension, the fluid reasoning, visual spatial, the working memory, and then processing speed. I love the way Dell Children's Medical Center said, cognitive late effects affects the way a person thinks, learns, and remembers. And this caught my attention because that is what school is all about. It's about going to school and learning and remembering what we're taught and thinking, and how all that comes together in the learning environment. So today I want to talk too about the most common cognitive challenges. Slower processing speed. That is the one that I see when I'm reading and reviewing these neuropsych evaluations. The slower processing speed is one that often I see where children can have, or young adults can have, high average superior intelligence in all areas. And then when I look at processing speed, it might be in the average area or low average. And what does that mean for some children? It means that when talking to them, you're going to get a delayed response back. And sometimes they tell me, I know the answer. The teacher calls on me, and I go to say, repeat it, but somebody else has already blurted the answer out. That's because they're processing the information and before they speak, and it takes them longer. It takes them longer to complete tests or complete their assignments. Some of our children have difficulty with word retrieval, and I think as we get older, we often have difficulty with word retrieval also. For the children who've been through treatment, it is called chemo brain sometimes, where you know what you want to say and it's just not coming to you quickly. Short-term memory loss, I think of that. I often hear from families, they're saying I'm helping them with their spelling words at night. They know how to spell them. They go to school the next day and they fail the test. And the child says, I get there and I forget, I can't remember. Or the teacher might let me know that they're having trouble in math. I'm teaching the same concepts each day, but it's like I have to start over each day. So the short-term memory loss. And then we talk about inability to focus, concentrate for long periods, the poor organization, the difficulty multitasking, and all that, falls under what we want to refer to as the executive functioning skills. And with the executive functioning skills, I often say that we have to start teaching these skills early on in the very young years. I have a lot of, in the private sector, I have a lot of families call and for their teenagers, and they want to set them up for the executive functioning workshops, and they're saying they need help organizing and prioritizing, and they need to finish their work and turn it in. Well, unless that teen is going to be committed to and wanting to make a difference in these areas, it's not going to work. So that's what I say. We have to start early with these children, teaching them to organize and plan. And that's where sometimes we can put accommodations on a 504 plan or an IEP that's going to help with this. So what happens when a child or teen returns to school and learning is different? Well, the first thing that comes to mind is the term, can you even imagine? Can you even imagine? And I think back to our younger children. They're going to school and, maybe they've learned their multiplication table, and now it's after treatment, they've after chemotherapy, and they're in 5th grade, and they're saying, I can't remember that multiplication table anymore. Or I have parents say that, for their preschoolers or toddlers, Alma, they knew their colors, they knew their numbers, but then after treatment, they have to start over. They're going, they knew their numbers and they knew their colors. What has happened? So we have to do a lot of work in that. Learning is different for these children. Children with brain tumors often have to start completely over. Sometimes after their surgery and radiation and chemotherapy, they have to learn all the skills over: how to walk, how to talk, how to feed themselves, how to use a writing tool, how to grip a crayon or a pencil and write. Sometimes their dominant hand was the right hand, and now it's the left hand. So everything is different for them. And how does that affect them? The child or teen might become frustrated, feel embarrassed, experience anxiety, lose interest in school, withdraw, or resort to acting out behaviors. All that can be traumatic for the family, not just for the child, but for the parents too. I know as a parent, our heart hurts when our children hurt. So I want to read to you something that a mother wrote to me the other day. School is not going well for Johnny. I am worried about him. The notes coming home on his papers are getting worse. They say things like, he worked on it for 3 days. He just sits there and talks. I set him in the hall and he still didn't do his work. Johnny worked on this for an hour. He is now doing no work, all talking and playing. I sent him to the hall and he still didn't work, the teacher said. Johnny told me his new seat is now in the hall by himself. He tells me his teacher doesn't like him. He tells me how he hates school and asks why he has to go every day. He is always coming up with excuses to stay home instead. He complains of stomach aches on the day he has school, hoping it will be a ticket for him to stay home. Last week I found out through the comments that came home in his folder that he had spent time in the hallway. When I asked him about it, he told me he was there 3 days in a row and was allowed to come in during snack time. I can't say how accurate that is, but at any rate, I'm sure that's how it felt for him. Johnny said, I'm a bad kid in the classroom and a good kid in the hallway. So maybe if I do both, then I will be a medium kid. I feel his self-esteem is slipping away more and more, and it breaks my heart. He seems to want to play with his friends less and less, and I have to push him more and more. So when I received this from the parent about Johnny, who is in 2nd grade, I was very disturbed, and since that time we've had school meetings, and Johnny is now in the class more, and we put more accommodations in place for him. But was Johnny frustrated? Absolutely. Was he probably embarrassed that he was always being put in the hallway? Absolutely. Did he have anxiety? Yes, in the morning he didn't want to go to school. He had a stomach ache. He was losing interest in school and withdrawing from his friends. And he was resorting to some acting out behavior by talking and not being able to finish his work. So when you have this situation, what do? What helps? A strong support system and partnerships, a school health plan, educational plans such as a 504 and IEP, accommodations, and in-service trainings for school staff and classmates. And I'm going to talk about each of these. A strong support system and partnership. Well, we have to have a strong support system between the school team, the medical team, the parent, and the child. Sometimes when I'm invited to school meetings or to go with the parent, they refer to me as an advocate. I don't like that term. I'm not an advocate. I am a partner. I'm a partner with the parent, the school team, the medical team, and the child. As I believe in the old saying that it really takes a village. It does take a village to support these children with cancer, and we have to approach it as a partnership. No one person has all the answers. We have to work together to make that life for that child returning to school as easy and successful as possible. So what are the components of the school health plan? I do know that every school division has their own school health plan, and we get a lot of them coming to the hospital, and we have to complete different portions of that for the parents. But the school health plan, it describes the chronic illness, lists medications given at school, outlines medical procedures that might have to take place at school, and lists accommodations that are needed for the medical condition. And school health plans need to be updated every year, so it's very important that the parent can request the medical dictation from the hospital and take that to the school nurse. So also I wanted to say that it's very important when we have meetings at school that school nurse is a part of the comprehensive meetings that we have, the school-based meetings, because that school nurse sometimes knows more about that medical condition than anybody in the school. So I always like to include the school nurse. And for all the school nurses on this called virtual conference today, thank you for being with us. Next are the educational plans, a 504 plan or IDEA, and I'll go into greater detail about these in a minute. But, I personally believe that, we talked about the late effects of treatment, and Dr. Gowda talked about the physical late effects. I'm going to talk about the cognitive late effects. Robin Dillon this afternoon will be talking about the social emotional late effects, and then Rich Catlett will be here talking about the spiritual late effects. You put it all together and then you put it into the academic and vocational late effects. So, we're talking about all the challenges that children face. And I do believe that, most of our children returning to school because of the late effects, they need an educational plan. And a 504 plan, as we all know, it is for children with health conditions. And then IDEA is for ones who have a disability and need more specialized instruction. So what is Section 504? It's a civil rights statute that prohibits discrimination based upon a disability. And I know we're talking about chronic health conditions, and you're saying, why are we talking about a disability? Well, a 504 plan is part of the Rehabilitation Act of 1973. So what constitutes a disability? A mental or physical impairment that substantially limits one or more major life activities. So there's your phrase there, physical impairment, because our children who have gone through treatment, they do have some physical impairments. A record of such an impairment, well, the clinic dictation is the record and is regarded as having an impairment, and that will be outlined throughout their paperwork on their medical dictations. So what is defined as an impairment? And here, any disability, long-term illness, so that's what I want you to key in on, the long-term illness or disorder that substantially reduces or lessens the student's ability to access learning in the educational setting because of a learning problem, behavioral issue, or health-related condition. So we have lots of keys here, long-term illness and a health-related condition. And it reduces or lessens a student's ability to access learning. We do know that happens because we've talked about the concentration and the attention. We've talked about the slower processing speed. So thinking and learning and concentrating are the major life activities. So I go to a lot of 504 meetings. So, a lot of times we look, some children who have gone through treatment might have a hearing problem. So maybe sometimes we'll mark that. But a lot of times it's the concentrating, the thinking, and the learning. And then what is IDEA? Individuals with Disabilities Act. And it's a federal law that provides funding for special education and provides a free and appropriate education for all students who fall within the special education category. You are the professionals and you're the teachers, so I don't want to really read all of this to you. Who qualifies? Children 2 to 21 years of age, inclusive, and who need special education or, as we said, specialized services for their learning. And here are some of the disabling conditions under an IEP, the handicapping conditions. And the one I like to use the most for our children who have been through treatment is that other health impairment. Sometimes I feel like families and parents, they don't need more labels for their children. Sometimes we do put a specific learning disability, but usually whatever is going on with them is related to their other health impairment. So what are some helpful accommodations? And a few that I put up here today, these are the ones that I use a lot when I'm working with schools. Preferential seating close to direct instruction. Permission to carry a water bottle and drink fluids throughout the day because of the medications they're on. We really need to push the fluids. Of course, the more you drink, the more you have to go to the restroom, so bathroom privileges when needed. Oral and written directions with clarification for understanding. Sometimes we all learn differently, some orally, some visually, some hands-on, but oral and written directions, because sometimes the child gets home from school and the parent is trying to help them with their homework and they're not really clear of what they're supposed to do. We might want to, due to the slower processing, chunking of assignments into small parts, where if you have a test and it's the top is matching and then you have fill in the blank and then you have true false, part A, B, C, maybe during test time they'll take part A and then they'll come back after lunch and take part B. So chunking of assignments and tests into smaller parts. Modified workload with emphasis on quality versus quantity. These children, fatigue is a big issue when they return to school. With the fatigue, it can last for months after treatment, and they're tired. Sometimes parents will say they come home from school and they lay down and fall asleep and they don't really wake up till the next morning. We want these children to have good quality time at home too. We have to create a good balance. So a modified workload, I hate when my teenagers are telling me that they're spending 4 to 6 hours a night on homework. So we say, can we have a modified workload? For math, rather than doing 10 problems for homework, can you show mastery in completing just 5 problems? Hard copy of notes, study guides, and PowerPoints. Sometimes due to attention and concentration when they're taking notes, it's just difficult to get everything written down. Also, a lot of these children, when taking notes, they might have neuropathy in their hands that makes their hands start cramping if they're writing for an extended amount of time. So hard copy of notes always helps. And then extended time to complete assignments, tests, quizzes, and projects. Time and a half or double time is often recommended. I find that for our teenagers who are taking PSATs and SATs, sometimes they say, I just cannot finish within the amount of time. So extended time is offered if they already have a plan in place, an accommodation on a 504 plan or an IEP that requests that extended time. There are other helpful accommodations, and you're going to have a list of those because I'm going to talk about the toolkit in a few minutes, and they will be in that for you. Another helpful accommodation is in-services for school staff and classmates. In-services is when I might take my puppet into the elementary classroom and I might talk to them about their classmate, and I try to break the talk down into being kid-friendly and age-appropriate. So the in-service answers questions, makes one less curious, makes one less afraid, where their classmates aren't afraid anymore. Everybody's more comfortable, and it offers helpful hints and suggestions on how to be a good friend. I'm going to tell you a couple of stories here. One time I was called to a daycare for a 3-year-old group, and the parents said, I want you to do an in-service. And I said, you want me to talk about childhood cancer to a group of 3-year-olds? And the parents said, yes, he's lost his hair and they're really afraid of him and they won't play with him. They're scared. And I said, okay. So I got my Fisher-Price doctor kit, and I got my puppet, and I went into the school, and I sat down on the floor, and I had the children around me. And on that particular day, I talked about big boo-boos and little boo-boos. And a little boo-boo is if you have a little scrape or a little cut, you might need a Band-Aid. But a big boo-boo might be one in which you have to go to the doctor or even maybe go to the hospital. So we talked, and I related the young man that I was there for. I related the conversation to him. And I said, and then sometimes we have to take medicine. And we talked about all the ways to take medicine. Sometimes you might have to take a little pill. Sometimes you might have to drink it in a cup. And then sometimes you might have to get a shot. And this, and then we talked about a portacath. And my puppet had a portacath in his chest, so they got to see what a portacath looked like. And then they got to see how the needle went into the portacath, and then the medicine would go into to the body. And then what happens? Then you have side effects from medications sometimes. And let me tell you, people, 3-year-olds know, if my mother gives me Benadryl, it's going to make me sleepy. And so they shared that. So that led into my conversation about side effects. So this young man had to take a medicine called chemotherapy, and it caused him to lose his hair. But you know what? It grows back. And then, so the hair comes off the puppet and it goes back in. Well, when I left that day, they were rolling around on the floor and they were rubbing his head, and I never had to go back again. It served the purpose. It was a great in-service for 3-year-olds. So, several years ago, I was asked to go to a class of 4th graders. And this little fella, I loved him dearly. Dad came to me, and he went back to school without a lot of preparation because everything we thought was going to be okay. But then Dad said, Alma, he won't take his hat off. He still has his hair loss. He has his hat on, but he won't get out of his desk because he doesn't want to raise any attention to himself. So, again, I took my puppets in, and I talked about the diagnosis and the treatment and side effects of treatment. And I explained that day, and it almost breaks my heart to tell it, that day when I walked to the door with my puppet to leave, this little fella, Danny, he took his hat off, he laid it on his desk, he smiled at me, and I never had to go back to that school because he then fit in. It was okay. You explained for me, and now they understand, and it's going to be better. And then, I had another, and this was probably 25 years ago. I went up in Fredericksburg, and I went to for a little young man who had leukemia, and he was in 2nd grade, and he said, Alma, I want you to bring the puppet and do that in-service. So I went up, and we did the whole presentation, and then he was in 3rd grade. He said, will you come to my school and talk to my 3rd grade class? And I went up and I talked to the 3rd grade class. And in this class was a young man who had a disability of his own. He was on the spectrum, and he took in every word I said about his friend who had leukemia. So this young man gets to be in 4th grade, and he said, Alma, will you come to my school and tell them about, my diagnosis and bring the puppet? And I said, well, you have your hair now. You finished treatment. You're doing wonderfully. Why do we want to bring attention to it? And he said, oh, will you please come? That particular day, I took the puppet and I went to the 4th grade class. He led the presentation for me. He used my puppet and he did it. And I never had to go back. At the same time, what I learned from this young man and his mother was that the classmates, he had a lot of the same classmates. The classmates were educating people in the bus and other people in the school, so everybody kind of had an understanding. So in just doing one class presentation, these children are so protective of their classmates if they understand. Now, if you don't do an in-service, and if you don't explain to them what's going on, they're going to be annoying. They're going to ask the same questions every day. And that is sometimes why I get these calls. This year I had a call this fall. Will you come and do an in-service for my child? Because he's back at school and he has his hair, but they started looking at the yearbook and they realized that last year he didn't have hair. So they're now saying that he has a wig. He's wearing a wig. And he's coming home really disturbed, saying they're being mean and teasing him, saying you have a wig because he has his hair this year. So I went in and did the in-service for him. And, he kind of helped me lead that in-service. And I'm telling you, I think he feels much more comfortable now, too. So the in-services are really, really supportive if they're done correctly. Now I want to tell you a little bit about something that we designed. It's the Ask Childhood Cancer Education Toolkit. And it was designed to support children and teens as they transition back to school following their diagnosis of childhood cancer. Why did we develop it? We realized in 2018 that approximately 325 children were diagnosed with childhood cancer in Virginia. We realized that it was some inconsistency in Virginia because a lot of these children did not have access to the resources, to an educational consultant, to in-services for their classmates. And so we wanted to offer them something that they could help educate their school staff and have a better understanding of how to transition back. So we developed 750 copies printed, and we sent them to all the 5 treatment centers in Virginia. And these were developed through the Department of Health and Ask Childhood Cancer Foundation. They provided the funding. So the toolkit is set up into 3 sections. The hospital section is completed by the child's physician, and in it is a school health plan. Let's say the parent hasn't been at school for several months, the child, and they're transitioning back. So instead of having the division school health plan, we have a little school health plan in there that can be completed. It offers a list of accommodations that the physician can check of what that child will need when returning to the school setting, and contact information for the physician and medical team if there's a problem at school, as well as resources in the community. The hospital section should be given by the medical team to the parent right when the child is getting ready to transition back to school. And then we have the parent section. In the parent section, it lists the common challenges that are outlined also in the school section. And we've talked about these challenges: the physical challenges, the cognitive challenges, the psychosocial emotional challenges, the academic challenges, the spiritual challenges. So it lists them all, it talks about them. And then, because sometimes even as the parent is going through treatment and they're at the hospital a lot, they're thinking, what am I going to expect later? What's going to happen? And then it offers the same list of helpful accommodations so that the parent can address and check each of the accommodations they think their child might need when returning. It offers us information about that school health plan. And it talks about 504 plans and individual education program, so that if a child needs an IEP or a 504 plan, the parent knows about these plans and how to advocate to get these plans. And the parent should review each section in the toolkit, and then they should share the school section with the designee at the school. It could be the principal, guidance counselor, coordinator of the school-based team. So, and then hopefully they're all going to come together, because the school section, after they give it to the school-based team, That lists the common challenges, helpful accommodations again. It offers suggestions for how to manage trauma and anxiety, because a lot of these children might have PTSD after treatment. And then it offers an explanation of why we provide the in-services and how that could be beneficial. So in providing all of these, at the school-based team meeting then, when everybody comes together, when the child is transitioning back to school, everybody has one of these little school section or parent section, and everybody has the helpful accommodation checklist, so that everybody hopefully is going to be on the same page of what that child's going to need. Our ultimate goal of the Childhood Cancer Education Toolkit is to create a strong partnership between the medical team, the school team, the parent, the child, so everybody comes together, because we want to ensure that each child has academic success. All children want to be successful. All children want to, they all want to be liked by their teacher. They all want to have friends. They all want to have someone to sit with them at lunchtime. They want normalcy. And they want academic success, and that's our goal. So, what do your students want you to know when they're returning back to school? So, through ASK, and ASK is such a big advocate and supporter of programs for our children, and over the years, they've provided funding for after-school tutoring programs, summer camps, middle school, high school retreats, young adult retreats. So I often ask my young people, what would you want your teacher to know? And here are some of the responses. A Hodgkin's lymphoma survivor, age 11, said, need more time for test. A rhabdomyosarcoma survivor, age 17, said, I had radiation treatment that paralyzed my left vocal cord and messed up the functioning of my soft palate. This caused me to not be able to talk as loudly and clearly. So when he first returned to school, I think the teachers were always saying, speak up, when really he couldn't speak up. He was trying the best he could. A leukemia survivor, age 9, said, when I get scans, I get nervous and I can't concentrate. An acute myeloid leukemia survivor, age 11, said, I have not been in school for 2 years and I may need more time and more help on my work. It has been so long since I've been on a field trip, so I might need a break, meaning if I go on a field trip, I might not be able to keep up with the group, so I might need somebody to walk with me a little slower. A brain tumor survivor, age 17, even though I look like an average student, I don't see as well as my peers because I have juvenile polycystic astrocytoma, where my optic nerves cross. I need extended time on quizzes and tests because it is visually draining for me, not because I want to have an advantage over my peers. And then another brain tumor survivor, age 8. I look younger because the cancer stopped my growth. A Wilms tumor survivor, and Wilms tumor is of the kidney, age 12, said, listen to why I can't do something rather than assuming that I'm trying to make an excuse. And then if I tell you I had cancer, I want it to be between us. And then an osteogenic sarcoma survivor, that's bone cancer, age 17, said, don't single us out. Sometimes it is hard to concentrate and I need breaks and extended time for test. And this is one by an age 34 acute lymphoblastic leukemia survivor. And for age 34, I just kind of thought this was kind of profound. Just because I'm wearing a smile doesn't mean I'm okay. And I think a lot of our children say this, and a lot of the parents over the years have said to me that sometimes it's just very difficult. I send my child back to school. Their hair is back. They look fine. They look fine. And teachers expect the same from them as before when they had their treatment before. My child will never be the same, they tell me. My child will never be the same. And I need them to understand that. Now, here's a group. Every year we have a group, we have a big graduation celebration at the hospital for our young people who have been through treatment and they're graduating from high school. And they write me the most beautiful, heartfelt, touching college essays that I've ever seen. And it's so funny because some of them can be 10, 15 years out of treatment, but it's funny how those essays always go back to what they went through. And I'm going to share a couple of those with you. A leukemia survivor said, "When the doctors told me I had leukemia, it changed my life. Although I was only 6 years old, I have vague memories. I do remember that I struggled a lot. I was bald and everyone stared at me all the time. I couldn't play sports or do anything physical because of my portacath. Inside it hurt, but it made me more determined to overcome cancer. In school, my cancer had a different impact on me. I was and still am an awful test taker. It took me much longer to understand concepts. I'd have to have things repeated to me a couple of times when other students understood right away. I also got sidetracked easily, and it's still hard for me to stay focused." And then one of my Hodgkin's lymphoma survivors. "As anyone might imagine, the diagnosis of cancer, particularly to a teenager who has so many hopes, dreams, activities, interests, and social life, the realization of having a physical problem that could seriously limit or eliminate many, if not all of these, was frightening. In addition to the physical limitations came the emotional ones, and combined they were very difficult. My ability to focus on those dreams and goals for the future was really limited at first. The physical effects of the chemo on my ability to concentrate and retain information I was getting at school were pretty bad. In the midst of all this treatment, I was trying to take SATs for college, and that was pretty difficult as well. My physical stamina was reduced, and I had to work doubly hard in trying to stay in some sort of reasonable shape. Then there was the feeling that you were different from everyone else because you had cancer. As chemo took effect and my hair came out, it was pretty tough too, especially for a teenage girl. So there were a lot of physical and emotional stressors that affected me as a student." So these are just some of the words of our children. Today, this afternoon, we have a panel discussion with parents and one of our young adults, and you're gonna hear right from their mouths what they went through and how they felt. So we will hear that later, and I hope you'll enjoy it because it was really fun to work with this group and with this panel. They really wanted to share. So that concludes my presentation, but I want to say before I leave, thank you for being here today. I have loved my work over the years. Today, it's a hard time, I know, in the classroom for teachers with all the challenges of COVID. But keep doing what you're doing. You're making a difference, a wonderful difference for these children and for these families. And thank you for wanting to make a difference. And I want each of you today to go back to your school buildings, and you are now going to be an expert in childhood cancer in your school building. So thank you all for everything you do for our children, for all the children. And I want to, one more thing. If you ever have the opportunity to teach a class or to work closely with a student with a chronic health condition, reach out and take that opportunity, because you have so much to offer them, but you are going to also learn so much from them. It's a give and take. So again, thank you for being here today, and happy Friday, and have a great weekend.
Alma, we have a couple questions. There's a lot in the chat, and I'm going to try to summarize, but I might just end up reading through the whole thing. Crystal Stinnett is a school nurse, and she initially asked, do you have case managers that follow the patients and survivors over the academic career that offer input into the 504 and IEP in schools for their children? And I said I would ask you that, but I wanted to clarify if she was asking about a hospital-based case manager, and she then continued, my understanding is that Children's continues to follow their survivors and patients, more of a clinic or community manager. And I responded, I will ask you, Alma, but that you are generally the person who follows all the kids at Shore through their education. And then Crystal said, I don't know if a parent has to prompt you to be included in the school meetings or if that took place. Not all school nurses become aware of survivors unless direct school nursing services are provided. So could you talk about that a little bit? Like, how does the school nurse get involved?
At VCU, we have patient navigators in some of our clinics. For our HEMOC, I am the educational consultant for the hematology oncology population. I get all my parents to sign releases for me. It's a release to work with the school division. So then I can contact the school and serve as that partner between the medical team and the school team. And when I reach out, and when children have 504 plans and IEPs, they have a case manager within the school system, within the school, that serves as their case manager. And the case manager and I often communicate back and forth regarding the medical and the educational needs. Did that answer that question properly?
I don't know, but Janetta Altizer also added,
let me tell Ms. Stinnett one more thing. I'm sorry, and because you said she's a school nurse. Ms. Stinnett, also I wanted to say, this past week, I had a call, and it was from a parent saying the school nurse said to reach out to you, that the school nurse thought this child might benefit from a 504 plan. And I praised that school nurse. I called her immediately and said, let's set this up immediately. Who's the 504 coordinator at your school? So if you think a child would benefit from a 504 plan, absolutely reach out to the parent and let them know, and let's get these people, partners, involved together. Thank you.
That sounds wonderful. I did want to add, because Janetta Altizer added in the chat, as a nursing supervisor in our schools, if the student has nursing services checked on their 504 or IEP plans, then we are available to advocate for the student and have input in their 504 or IEP plan. So.
And that's wonderful, and because I always usually tell the parents that I'm working with, and if it's a school meeting, to ask that the school nurse be present at the 504 or the IEP meeting, because I think the school nurse has so much to offer.
Crystal did then add in the chat that you answered what she was hoping for, so thank you. So, yes, okay, thank you, Alma, so much. I'm going to come up and make my formal thank you, but we are available now for the slide with your survey. Thank you, Alma, for joining us this morning and helping us to understand what childhood cancer patients and survivors face when they return to school and how they can successfully transition back to the classroom. If you have any more questions for Alma, her contact information is on the presenter information page in your folder. We will now take a 15-minute break to give everyone a chance to stretch their legs and take care of anything that needs to be done away from the computer. I realize that we're running about 20 minutes early, but we're going to stay on this. So we'll come back at 10:55. So we'll see you back here at 10:55. Thank you. Welcome back. Our next presenter, Michelle Jarnigan-Johnson, is the Launch Project Coordinator here at Ask Childhood Cancer Foundation. Michelle has worked in the public school system as a diagnostician, special education teacher, and administrator. As our Launch Project Coordinator, Michelle works with our teens and young adults to help them find their path, feel supported, and hopefully launch into adulthood. Please welcome Michelle Jarnigan-Johnson.
Good morning. I'm Michelle Jarnigan-Johnson, and as Denise said, I work as a teacher. I worked as a teacher in 2 school systems, a diagnostician, department chair, special education coordinator, 504 coordinator, and then I moved into working with the Virginia Department of Education through their hospital education program for 12 years as an educational consultant. For the past 3 years, I've been with the Ask Childhood Cancer Foundation as a launch project coordinator. So with the challenges that our teens, young teens and young adults face, I hope that I can share some insight I have with how you can incorporate some of what they may be challenged and faced with into getting involved with their post-secondary options. In addition to the challenges that most young teens and or older teens and young adults face, they have such as adolescence, all those changes that they go through with adolescence and that kind of thing, and worrying about, how they're going to fit in as adults, how they're going to be as adults. Children or young adults with cancer and have other challenges that, in addition to the challenges that I just mentioned. They have problems with physical appearance because they may have had a leg or arm amputated. Sometimes their face may be dysmorphic. They face some changing priorities, such as when they are on chemo or radiation, they may feel one day that they can do one thing, and then the next day that changes because there may be some changes in either their medication or the amount of therapy they may be receiving, so their priorities change. On the flip side of that, you could say that because their priorities change, they may be resilient in that area because they've learned to compensate. And so that shows us that they exhibit some growth there. And that's one good thing that you want to see. But there are other times when those priorities change and it really devastates them. They may have problems with social relationships. Their peer groups, because of the radiation and chemo, all the therapy that they receive, being out of school for, a few months to even up to a year, their social relationships are really depleted. And so they feel outcast. The anxiety, the depression that they feel is insurmountable to some of them. And there's some that experience survivorship guilt. They feel, why am I still here? And the survivorship guilt comes in when they've made friends with someone who's in therapy just like them. And unfortunately, that friend may pass away. So they've experienced what we call survivorship guilt. They may fear failure a lot of times, but sometimes the fear of success is insurmountable as well. They may feel that they have good grades and they're doing well in school, but what happens with those grades? What happens if I go to college and I fail? So the fear of success is just as bad as having the fear of failure. Some of them, or a lot of them, seemingly lack motivation, but it's not so much the lack of motivation that they experience or that people think that they see in them. Is something like a paralysis. I think. For instance, I was prepared to tell you the story about a young lady that I was working with who was diagnosed when she was in the 10th grade with cancer. And then she spent the better part of her 10th grade year out of school and started her junior year back in school. And she was angry and mad at the world. But just this week, actually Monday, in our survivorship clinic, I met a young man named Justin who's 23 years of age. He was escorted to clinic by his mother. And you might say, well, if he's 23, why would he be escorted by his mother? Well, she was there because she helped us to fill in some of the gaps. He was in elementary school, he was labeled gifted. And when he said that he was gifted, she interjected that he went to a certain elementary school, and I knew that elementary school housed gifted students. And so she went on to say how good he was in school, and he interjected some things with his school success through middle school and high school. They didn't feel that he needed much by the way of accommodations, for getting back into school after treatment. But he went on to college, and in college, he was accepted to a college, and in college, he bombed. He really did not do well at all, and after a year, he left school. So that was at the age of 18 and 19. And at 23 years of age, he comes to Survivorship Clinic for the first time. And so we asked the question, did you feel a certain type of paralysis? And if you could have seen the look on his face, like, somebody gets me, somebody understands that I just felt stuck. I just couldn't move. I just couldn't do anything once I got to college. That's where we can tell you that a lot of kids seemingly do well in high school, middle school and high school, but that paralysis starts to sink in because they still experience some things with late effects that Alma may have mentioned to you. And so it's really important that in the transition plans, we incorporate, even those on a college track, certain things that you can put in and incorporate in those plans to help them transition from high school to college. Executive functioning, I found that not only is their working memory impaired some, and with Justin, maybe not so much his working memory, but his initiating, the planning, the self-monitoring, all of those with those executive functioning characteristics. Justin has those. And so if we could incorporate some things that from secondary to post-secondary, with as far as college is concerned, that would be a great thing that you could incorporate. I found that a lot of times when people are on a college track and they seemingly are doing very well in high school, there's a tendency to think that they might not be in need of some post-secondary monitoring. So if that could occur, that would be a great thing. One of the things, or the primary thing that we do for our students with disabilities is we link them with the Department for Aging and Rehabilitative Services, which is DARS. And in high school, every high school is assigned a DARS counselor. And they have been very instrumental in working with our kids, our young adult cancer survivors. Some of you may know that DARS utilizes job placement. With our college students, they can assist with assistive technology devices. They can offer community resources for those who are on a vocational track, and those who go on to college. One of the other things that the Department for Aging and Rehabilitation Services also does is they house or they oversee the Program for Adults in Vocational Education, which is PAVE, and that's housed at Reynolds Community College in Richmond, Virginia, on their downtown campus. And the young man I'm hoping to your left, graduated from PAVE last year, and he was in culinary arts, and he received a certificate for that. He started working at a restaurant, was promoted to second chef, and now is working at another restaurant where he is shadowing someone as head chef, and he's also working with his father in his father's business with a food truck, and I'm told that they're being very successful with that. Under PAVE, also, we have two people in their clerical program who will graduate in May of this year. So we're really proud of the work that DARS is doing with them. And I highlighted them this young man, because he didn't have DARS to look after him in high school, to get him started and to get him registered. And that took him a while to. The longer you wait to get acclimated with the Department for Aging and Rehabilitation Services, the longer the wait is. And so it's really important that in high school we start to get them acclimated into getting those services through DARS. Having the DARS counselor who's assigned to your high school, know the kid, and to start to register him by, depending on the disability, his junior year, but definitely by his or her senior year. DARS has also been helpful with getting kids into the Woodrow Wilson Workforce Center, and now it's called the Wilson Workforce Center. And we had a field trip this past year, and if you don't know anything about the Wilson Workforce Center, they have a dormitory-like campus, and depending on the field that you are interested in or you want to pursue, they have anywhere from a 6 weeks course to a full year's course. And you could go for a plethora of career and vocations that they have: IT, welding, carpentry, early childhood education. You would get a certificate in that. So they have a plethora of things that you would be interested in, or kids would be interested in. Cosmetology is another big one. The young man on the right in the plaid shirt is named Tristan. He'll be going to Woodrow Wilson or the Wilson Workforce Center in April of this year for welding. Like I stated, he was in the picture with the field trip, but his his transition plan in high school didn't include a DARS evaluation or a DARS counselor. And so we basically picked up the pieces there to get him a DARS counselor to work with him, got him on the field trip, and now he's and that Woodrow Wilson was something that he really wanted to work toward going, and so he's going there, like I said, in April. A lot of people think that kids that are going to college don't usually need the help, but our cancer survivors usually need a little bit extra. And so their transition plans are just as important, like I stated before. On those transition plans, you could write that they would be looking at scholarship information, and you can the guidance usually does that. Your guidance counselors usually do, they do that. Your career counselors at your high schools may also be involved, but that would be a good thing to put on the plan, because a lot of times if things happen with kids and their therapies, or they suddenly become, like I stated with Justin, stuck or paralyzed, they can look back at plans and they can remember that, oh yeah, I was supposed to do this. It would be good if I took a college tour. It would be good if I could get help on my college essay, or get information about financial aid sessions, and information about assistance from financial aid, or just help with completing college applications. Like I said, that's usually guidance, and a lot of people, special educators, don't think that they could put something like that on a transition plan, but it would be really good if you did for our young adult cancer survivors, because we never know, and they won't know when they become paralyzed. Some of our young adult kids in high school also could use an extra boost. A lot of schools offer SAT prep during the summer. There are a lot of colleges, for instance, the University of Richmond offered an SAT prep this past year, but our kids usually need a little bit more as far as one-to-one and not so much group assistance. So if you know of anyone who can conduct a college boot camp where they get help with those things that are listed, the one-to-one assistance with essays, any tips on writing, assistance with completing certain applications like the Common App or the FAFSA, and then we would offer the SAT prep for our survivors as well, and it would be good if your high school offers SAT prep. That's something that doesn't mean that the student will actually attend, but that's something that would be on the plan so that you could follow up, afterwards. Did you need extra help with the math or the reading? And those students list at the bottom, most of them didn't really need the help. They just thought that they did. And so we offered it for them. And so, because they felt insecure and they felt like they needed the additional assistance. And so you never know if, even if they're getting A's in high school, they may still feel like they want the assistance, but they just don't want to make mention of it. So if you could and write down some of that assistance that they may need, that would be very helpful. Social opportunities for our young adult cancer survivors is crucial. And I think that really is the most crucial piece, because peer groups can do a lot to help with relevance, establishing some sort of purpose, a sense of purpose, social relationships. It really helps. If you can get your student involved, even in a very minute way, in something social, it would help. We find that our social gatherings are the best thing going, really, because not only do they talk about their treatment and what's best, how best to take 8 different types of medication, or when is it best, or what do you eat with the 12 different types of medication you have, because a lot of our survivors are still on medication, even though they're seemingly normal in school and going about their daily routine. They still have medication requirements, and a lot of it is for life. So, I mean, they talk to each other about that, and they just have a really, really good time with each other, because there's someone who's, gone through or is going through the same thing that they're going through. So any type of social opportunities, and I know you can't be specific on those plans, but if you could incorporate something to say that they're involved in some type of social gathering or some volunteerism, anything that helps them to get out and be a part of the community would be really good. This is Jaquan. He graduated, and I said without an appropriate transition plan, but if I could be very honest with you, he had nothing in his transition plan. I viewed his IEP, and he had no plans as far as transition from school to work was involved. So we registered him with DARS, but before DARS could start to work with him, we involved him in a class for personal care aid. He received his certificate, and then within 3 months, he got a job at a nursing home. And to date, he is still working there. So that was a real highlight for us at the Ask office, because he was sitting at home and didn't have a plan as to what he was going to do and how he was going to do it. He was interested in culinary arts, but at the same time he was taking care of a relative, and that's when we posed the personal care aid to him. Now, he's not working now as a personal care aide, but he is working, and he loves working. He loves making money. So, that's a big plus and some real success for him. Other ways you can help. At age 14, and I know many of you know the law, the federal and state mandate, but begin at age 14 and make sure you continue that through until graduation. And like I said, college people on a college track need to have transition plans intact just as much as people on the vocational track. So the academic achievement for college kids is self-explanatory. I mean, they have their grades, they have guidance counselors who will continue to direct them, and but functional performance, that's just not for students with cognitive disabilities, or have below average cognitive functioning. Functional performance can be anything like, is he coming to class on time? Is she turning in assignments on time? or is she inconsistent with turning those in those assignments? So that could be a functional, that could be a functional characteristic that you may want to list and have them to work on. Make sure that in your plans that you're facilitating movement from high school, which is secondary, to post-secondary activities. And it doesn't always mean that there's going to be from school to work or from school to college. It could mean social activities, volunteerism, anything to get them acclimated to the community at large would be a post-secondary option for you to incorporate on your transition plans. You can continue to explore post-secondary education, career and technical education, and a lot of our community colleges, and in fact, every community college in the state of Virginia has a workforce center. And so you could have them to explore that option, for employment or for technical education. And for all of our students, you could examine their independent living skills and adult services. Other ways you can help, ask your career counselor, if there's one in your school, for if they could be involved in some type of informal or formal career assessment to make sure you're on track with that and to incorporate that into your plan. You could also observe your student as well. And like I alluded to before or stated before, your observations that you see in a student who needs to work on improving his assignment completion or getting to class, getting to school on time, though, those are your observations, and you can incorporate those into your transition plan. And then being able to provide information on various community resources that the student may be interested in at that time, you can incorporate, because it's really important once they leave school that they have some type of plan, some option, and you never know who's going to be looking at those plans when they get out of high school, once they give them to us. And so that gives us pretty much a working document from the school to say, okay, they did at least talk to you about this, and then the student may say, even though it's written down, no, they didn't, but at least we know that there was something that was discussed and something that was stated, and not just a blank piece of paper. And for the most part, schools you all do that. You do your due diligence. But with the college kids, I just don't want you to think that they're okay and that they pretty much know what they're doing because they're getting all A's and they're going to this school and they've got early acceptance. Those kids need it as much as our kids with limitations. We highly recommend comprehensive assessment, and that may be difficult with your IEP team or eligibility team at their 3-year evaluation to ask for an educational and a psychological, but for our young adult cancer survivors, it's critical that they receive that, because things change with them with treatment. They may seemingly be doing well in school, but there may be an area or two of processing that will probably devastate them if they go to college or they enter the workforce. And so we want to be prepared for that. If you could get them to conduct the educational and psychological, or the educational and some type of cognitive evaluation like the Woodcock-Johnson. A vocational assessment, an in-depth one, is also crucial to our young adult cancer survivors. And I put Google over there to your on the right side of your screen, because you, I didn't have Google when I was in, when I was teaching and when I was an administrator, but if you Google those community resources, you don't have to be specific with what they are, but if you can Google about the volunteerism and those kinds of things, I mean, they're out there, and Google can be your best friend with that. Google also can tell you about some of the informal assessments that you can give that only take 10 minutes. And so if you could do that and find the time, and I know when you're co-teaching and a lot of the students, most of the students are within general education classes, that's probably harder to do, but it's necessary. And if you can include an entire class with an informal assessment, career assessment as a fun thing, that would be something that you could do as well. And so this is why I'm here. This is why we launch. We get our young adult cancer survivors, acclimated into the world of adulthood. Whether you're in a community college like the young lady at the computer and you need some assistance, or you're a recent high school graduate getting ready to go to college, or you have your own business, or you're a special education teacher, as one of the gentlemen in the back, or you in real estate, you're doing well in real estate, or you're a recent college graduate like the young lady at the top, or you're in college like the young man sitting there with his care package, doing well in school, or you're on a vocational track like the young man at the bottom, because of the help from the community that we get, and because of some of what you have done in schools, this is why all of them have smiles on their faces. So I thank you. And we always look to other people paving the way for us. Thank you.
Thank you, Michelle. There are no questions from the chat feature at this time, but thank you. Thank you, Michelle, for joining us this morning and for sharing the information that you've gleaned from working with our teens and young adults. If any more questions come up after today's presentation, Michelle's contact information is on your presenter information page in your folder. Now we'll take a break for lunch until 1 o'clock. I know we're running far ahead, so we will break until 1 o'clock and then we will resume at 1 o'clock. If you have any questions while you're on break, you are welcome to type them in the chat feature and we'll come back and try to answer them. Thank you so much. We'll see you at 1 o'clock. Welcome back. Our next presenter, Robin Dillon, is a licensed clinical social worker and a certified advanced children, youth, and family social worker with degrees from Virginia Tech and VCU. Robin currently works as a clinical social worker in the Department of Care Coordination, Division of Pediatric Hematology Oncology at VCU Medical Center. Please welcome Robin Dillon.
Thank you, Denise, for that lovely introduction, and thank you all for allowing me to be here today to speak to you on the emotional impact of childhood cancer on patients and their siblings. I found this on the internet. It says it's from Jeff Foxworthy. It says kids are not supposed to have cancer, they're supposed to have a future. And I find that this is both true and not true because kids can have cancer and have a future, and it is our job to help them find that future. Childhood cancer diagnosis and the treatment journey can result in a great psychosocial burden on the families, and this includes every member of the family, the patients themselves, the parents, and the siblings. From the time of diagnosis through the treatment and on into the years after treatment, families can be impacted by both acute and chronic emotional issues related to their cancer. When we talk about the psychosocial concerns, we're looking at those issues and concerns that contribute to a child's well-being and sense of security. And when we talk about the psychosocial care, we're talking about caring and supporting them and their physical well-being, their emotional and spiritual wellness, their cognitive abilities, and their social and family functioning. We're looking at care in the broad sense and with a larger system that includes not only the patient and the family, but also the healthcare team, the community, which includes school and their peers. Physical effects of childhood cancer have been talked about earlier today, as well as the cognitive effects of childhood cancer. So I'm going to focus a little more on the emotional and social impact of childhood cancer, not only on the patients, but on their siblings. So first, the kids. Let's talk about those feelings, emotions, and behaviors of a child with cancer at the time of diagnosis and during their treatment. Each child will experience cancer very differently, and their cancer journey will be different depending on their social determinants of health, and that's looking at the family dynamics, that's looking on financial security, food security, and the support that they receive. It's going to be looking at any strengths and weaknesses that the family has, as well as any premorbid or comorbid conditions that might be going on at the same time that child's been diagnosed with cancer. It's also going to depend on their age and their developmental stage that the child with cancer is experiencing at the time of diagnosis and treatment. So some common feelings that they might feel. Anger is a huge one. Anger is a normal and expected response to a loss or unwanted change in our lives, and it's a common response to any life-threatening illness. It's nobody's fault that the child was diagnosed with cancer, and since they can't direct their anger at the cancer, the anger gets directed at the parents or the healthcare team or even the siblings. They may be angry and not know what they are angry at. They can be angry at the unfairness, at all the intrusions, at the pain, at the loss of normal childhood. They can be angry at their parents for allowing this to happen to them, or angry at their parents because they are the ones that bring them to clinic for the painful and unpleasant treatments. They might be angry at their parents because they are enforcing the rules that they can't go to school or go out to play with their friends. Sadness and grief is a tricky and complex process. Everyone recognizes that grief is something we experience when we lose someone close to us. However, sadness and grief shows up in many other life circumstances. Sadness and grief is a normal response to loss. such as when the life as you had planned it has changed with the diagnosis of cancer. Your future is uncertain. The plans that you had made are no longer able to happen. And much like grief and sadness that's experienced with death, there are steps to dealing with grief and sadness associated to the diagnosis of childhood cancer. Shock, bargaining, the aforementioned anger, and some acceptance, which is necessary to move through the cancer journey. Blame. Kids can place blame on themselves, feeling like they did something to deserve this, or place blame on their parents for allowing this to happen. Stress. Childhood cancer is an extremely stressful situation, not only for the patient, but for the whole family. Stress begins at the time of diagnosis, when the families are confronted by the tremendous burden of understanding the disease, the medical terms, and the treatment, and facing the possibility of a child's death at a very young age. Family life is disrupted as families struggle with a new normal that consists of frequent hospitalizations, overwhelming medical bills, and a questionable future. Indifference is a possible feeling or emotion that these children might be feeling. Things just don't matter anymore. School could become a focus, or they could become disinterested. They could become unmotivated on their self-care, such as their hygiene, or unmotivated to do their normal activities. They can seem disconnected or shut down. And fear is real on many levels. These kids may have fear of needles or coming to the hospital, fear of painful, uncomfortable procedures, fear of yucky tasting medicine, fear of death. Kids might have fear of being separated from their parents or fear of being away from home. Some may be reluctant to share their feelings of fear. They don't want to be judged or seem different. They feel like they have to be brave and put on a brave face for their family. And embarrassment is actually a feeling that these kids experience. As mentioned earlier today, there are multiple changes in physical appearance, such as hair loss or scars. Self-image and appearance is significantly related to self-worth and identity. They may be embarrassed that they have cancer. They may be reluctant to go out in public or go to school even if they're able to. They may not want others to know that they even have cancer. Burden. Children can feel burdened and guilty at times. They see their other family members in distress and might believe that they are the cause of their distress and pain. They might overhear mom and dad arguing about paying medical bills, or aware that the parents have to make sacrifices to bring them to clinic or be with them in the hospital. They may feel guilty for taking up all of their parents' time, especially if they're siblings. And loss. We've mentioned this several times throughout the day. There's a tremendous amount of loss. There's a loss of control, loss of function, loss of choices and decisions, loss of independence, and a loss of their social life. This loss of independence is extremely frustrating and a very fine line between wanting to be able to be independent and take care of themselves, but also wanting to be taken care of when you're feeling bad and ill. The need to lean on parents for support can be a big struggle for teens. Needing assistance with bathing or toileting at an age where you're supposed to be out driving, being independent, is very difficult. There's a huge need to try to control things in their lives. Frustrations and irritability is often present, sometimes due to the external influences with all these changes and loss, but also certain medications such as the steroids can make the kids super moody. And there's also some existential feelings that come along. What did I do to cause this? Why did this happen to me? What does the future hold for me? And what does this mean long term with regards to a relationship, a family, a job? So what are some of these behaviors that result from these feelings? These are some behaviors that we might see. these kids experiencing either when they're on homebound instruction, when they are in the hospital, or as they're returning to school. The disruption of routine. Most kids have a decent schedule prior to diagnosis or before they start treatment, or at least have a routine that they're familiar with. After diagnosis, this is disrupted, and each week can be different with regards to appointments and medication schedules, missing school altogether or intermittently. There are changes in the sleeping and eating patterns, changes in the play and other daily routines. Regression. A lot of times we see that kids might regress in their independence and milestones. We've seen kids who were potty trained now need to go back using diapers. The teenagers who were independent, driving themselves to their school practices and independent in all of their activities of daily living, now need assistance from their parents to bathe or dress or walk to the bathroom. And isolation. Kids undergoing treatment for cancer are often isolated due to the compromised immune system. They're isolated from their peers, they're unable to attend school, participate in sports or play dates or other social activities. They can become withdrawn, and this can lead to depression. Even healthy, well-adjusted kids can have outbursts or tantrums when they are overwhelmed with strong feelings. Younger kids can yell and scream more than normal and become really uncooperative. Older kids may rebel against parents, their providers, or their teachers, making the treatment and the care much more difficult. The emotional impact of cancer is very pronounced, especially when physical changes and losses of ability are concerned. While this can be present at any age, it is especially true during the teenage years, a time where appearance is particularly important. When adolescents look different from their peers, their identity is challenged, and that can lead to low self-esteem. And during treatment, most kids of any age will have trouble sleeping, either excessive sleeping or interrupted sleep or inability to fall asleep. And of course, lack of sleep or changes in sleep patterns coupled with excessive worry can create extreme fatigue. All of these things, the disruption of routine and isolation and low self-esteem and fatigue, can lead to poor academic performance. So how can we support these kids during their treatment? We can keep serious conversations age appropriate. Remember that communication can be verbal and nonverbal. Kids are often listening even if they're not talking or otherwise participating in the conversation. Younger kids may not be able to grasp the seriousness of the illness compared to the older kids, but still age appropriate and honest and straightforward information does work best. We try to be honest and straightforward. This will hopefully alleviate any mistrust. We do encourage the use of the word cancer or their specific type of cancer. We try not to avoid it, and not using it may lead to issues of mistrust and confusion. We focus on the emotion and the behavior in the moment, talk about or address the behavior in the real time. If they are feeling frustrated, deal with that frustration, and then deal with the whys of the frustration after they have calmed down. We focus on minimizing self-blame and positive aspects and have a safe outlet for emotions. This can be in the form of a physical activity, as an outlet for an aggression, or talk therapy or art therapy as an expression of emotions. Avoid situations that create an emotional overload. Decrease stimuli that overloads the senses. And foster inclusion. These kids are feeling different and detached and distant, so anything that we can do to include them with what their same age peers are doing is great. We also like to offer a sense of control or choice. Providing reinforcements for participation and compliance with their meds or procedures is great. Offering choices when to take their meds or when to do something or how or with what is always a great sense of control. And again, establishing that routine, providing a structure that will increase sense of control, still imposing expectations and providing consequences will help maintain some normalcy, but providing structure is really important. While the patient is out of school, you really want to keep the teacher and classmates involved. Find out what the kid and family wants to share with the, there we go. I think I'm on the right one now. Find out what the kid and family wants to share with the school and their classmates. Encourage the classmates to stay in touch, either by video chat, Zoom classes, Zoom time, writing cards, even doing a drive by the house if it's okay with the family. Have an in-service for the class prior to the child's return so they can ask questions and get their answers. And remember to not only talk about the child's illness, but talk about everything else that the child is involved and interested in. So now I'm going to switch gears a little bit and talk about after the treatment, because this is when a lot of the kids will be returning to school. And there's mixed emotions. You know, post-treatment and after treatment can be an exciting but also anxious time in the cancer journey. While the child is no longer receiving treatment for cancer, they may be receiving treatment for ongoing side effects or late effects of the cancer. They will still continue to be followed closely by the healthcare team and monitored, and will continue to have medical appointments that will cause them to miss school. What the children and families have gone through is life-changing, and life may never return to pre-cancer normal. It may take time to adjust and find the new normal. The last day of treatment can be a time of both celebration and fear. While the end of treatment can bring a sense of accomplishment and joy, most kids will also experience other emotions simultaneously. Most children will want to return to the life that they lived before the diagnosis and treatment, but many will not be able to. The physical limitations, cognitive difficulties, ongoing medications, permanent changes to their physical appearance can limit their participation in some activities and be a constant reminder of their cancer experience. They may have to undergo testing on a regular basis, and they can feel disappointed and frustrated that it's not actually over when the treatment ends. There might be ongoing worry that the cancer will return. These kids relied very heavily on their healthcare team during their treatment, seeing them weekly, several times a week, monthly while on treatment. They develop very strong bonds and relationships. As they come off treatment and move towards survivorship, these relationships will be less and less. There might be some loss of experience of loss with these relationships. Might feel like they're being abandoned by their healthcare team that they spent so much time with. There's also a sense of security in going to the clinic and with that close monitoring, taking the medicine. When that is taken away because they've ended their treatment and done what they're supposed to do, there could be a feeling of anxiety because taking that medicine every day or going to that clinic every week is a security blanket in that cancer experience. For years, there's been a focus on doing the treatment to get well, and it's hard to shift gears and focus on something else. They may be worried that they're behind in school. They may be questioning what is normal now. Pre-diagnosis life has changed forever and there's no longer treatment, so what now? They might be worried about reconnecting and reestablishing their peer relationships. Remember, life outside the hospital and the clinic continued. A patient's peers or friends or classmates are continuing to grow and develop socially while they're in school. But a kid on treatment, their social growth and development is occurring inside the hospital walls. Life did not stop. A patient's life went on, but it was focused on medicines and treatments. Their friends' lives went on, but it was focused on normal stuff. what was happening on social media, what the popular TV program was, who's dating who in school. The patients might find typical issues seem trivial when they return to school. They might have trouble relating to their friends. What once was important to them may no longer be, and reconnecting with their peers might be hard. Childhood cancer survivors report engaging in 50% fewer social activities on average than their peer counterparts. And engaging in fewer social opportunities is directly related to lower perceptions of self-worth and lower self-image. So what does this mean for the future? There's going to be a lot of focus on ongoing medical issues and side effects of cancer treatment. What is the insurance going to cover? Is this a pre-existing condition? Will my cancer experience impact my ability to get a job or go into the Army? Will I be able to have a healthy, loving relationship? Will I be able to have a family? These are all questions that childhood cancer survivors have. And just remember, because the treatment ends doesn't mean that the kids and teens are no longer experiencing some of those strong emotions that they did during the actual treatment. The anger, the sadness, the blame, the stress, indifference, fear, embarrassment, the burden, the loss, frustration. They still might be dealing with some of these emotions as well. And just because a cancer survivor looks like they're doing okay, they may say they're doing okay, most still are wrestling with a host of conflicting emotions. And again, how can we help? Acknowledge the mixed emotions. Allow time for processing. Encourage a normal routine and help them find a normal routine. And please don't expect them to just get over it. Encourage an expression of these emotions. There's a lot of myths and misinformation out there, such as cancer is always terminal, or that you can catch cancer, or that someone did something to cause the cancer. So helping dispel these myths, especially for the peers and classmates as they return to school, is really important. Ask the parents and the kid what information they want to be shared with the classmates. They may have lingering feelings of concern or fear, and so identifying a safe person at school that they can talk to can give them a sense of control, knowing there's a plan and support in place if they need it. Promote empathy and acceptance with the classmates. And be aware that the classmates may be uncertain how to act or what to say. Discussing healthy and helpful ways of communicating and including the patient as they return is important. And remember that some kids return to school looking a little different, perhaps an amputation, a scar, their hair did not grow back, and they can be vulnerable to bullying and teasing, so please be aware of that when working with the classmates and peers. And again, then there are those kids that look exactly the same they did before they left school, but they don't feel the same. So remember, just because they look normal doesn't mean that they actually feel normal. I found this on the internet, and I cut off the who quoted it, but I think it's on there a couple of times, and it might be unknown. But this struck me as really a good snippet of what these kids with cancer go through. Kids with cancer, they ride tricycles in the hallway, not in the park. They know the names of their chemos instead of their classmates. Their central lines have names. Their nurses and their doctors are their new family. They think hair is overrated, and their laughter can make a grown person cry. If you've ever seen a kid fight cancer, it will change your life forever. Now, a little bit about the siblings, because a lot of you guys will have siblings in the classroom or at your school. And you're going to see that a lot of the emotions and feelings and behaviors that the siblings go through are same, but they might be experienced differently. When a child's diagnosed with cancer, how it affects the siblings must also be recognized. Most of the attention will be on the ill child, which leaves little time and energy for the healthy sibling. Depending on the age and the family situation, siblings can display a variety of emotional reactions to their brother's or sister's diagnosis and the changes in the family that this causes. A kid that has a brother or sister going through treatment for cancer is struggling almost as much, albeit differently, than the child with cancer. What bothers the siblings? They may be afraid that they somehow did something to cause the cancer. They might be afraid that they will catch the cancer. They may be afraid that their brother or sister will die. They may be afraid that their family is just plain falling apart. They may be upset they may be upset at the sibling or the situation in general, and thus try to avoid being around the sibling. They may display anxiety due to the disruption in their routine or the lack of understanding about what is happening. They're worried that the adults in their life are stressed and worried. They may be angry that their sibling got sick and caused this disruption and blame them for all the changes in their family. They may feel jealous of the time and attention and the gifts that the sibling is getting. And they may actually feel left out or feel their parents do not love them as much and feel abandoned. They may feel guilty that they're not the ones who are sick. They may feel guilty that they caused the cancer. They may worry and feel sadness about their sibling. What happens to them when they go to the hospital? What happens to them when they go to clinic? They could worry about their ability to cope with their sibling's illness. Cancer treatment is a very long process, and they may worry that their sibling will never get better. Or they may worry that something bad will happen to them or their parents too. They may feel isolated from family members or isolated from their peers and activities. There's a lack of attention from parents as the parents are with the ill child, so the siblings are shuffled to stay with grandparents or other family members and feel very left out. They may experience acute and chronic stress related to all the changes, both long and short term. These siblings might experience increased responsibility with chores, or they have to sacrifice on things like having to get up a sports or a club because the parents can't be at the hospital with the ill child while taking the other kid or the sibling to their soccer match. They may experience lack of control that comes with changes in the structure and routine and the expectations. They actually might be embarrassed of their brother or sister during times that the chemo causes hair loss or periods that they're on steroids and puffy. They might be embarrassed about how their friends will see them or treat them. The siblings also experience a loss of normal childhood due to the changes in the family roles and the disruption of routines. We may see these siblings having a lot of behaviors as a result of these emotions. Some kids may act out as they try to deal with these new and distressing emotions. Some younger siblings might actually get physically sick as a result of the stress and worry and the disruption of routine. I've had other siblings pretend to be sick because they see all of the attention and the gifts that the kid with cancer actually gets. Some kids may act as if they're okay as to not upset their parents more than they already are. They might resent the changes in the siblings, resent the changes their siblings' illness has brought into their life and become moody and even mean. They may get lower grades in school than usual, have a difficulty paying attention, focusing, may be very, very tired or fatigued. How do we help the siblings? We normalize these feelings. All of these feelings are a very normal reaction to an extremely abnormal situation. It's okay to feel this way. Most siblings feel this way. Involving the siblings in events around the diagnosis in an age-appropriate manner, such as involving them in discussions, not trying to shield them or hide them. Sometimes parents want to protect the child by not telling them anything. This can lead to a lot of issues of mistrust. Reassuring them that the cancer is not contagious and they did not cause the cancer. providing information on the diagnosis and treatment in an age-appropriate manner, answering all the questions honestly, making time for the siblings, arranging access to the treatment team or the hospital or clinic. A lot of times they just have no clue what's happening when their parents and sibling is away getting treatment. So being able to see what the hospital room looks like, FaceTiming, videoing, actually having them come down there can help normalize what's happening with their brother or sister. Encourage expression of feelings and emotions. Arranging for management of daily life at home, and this could be with a family friend or a relative. Providing assurance that the family will be able to handle this crisis and get through this crisis. Informing the siblings, teachers, and coaches of what's going on. Encouraging usual involvement in school activities. Bring up the siblings when people focus only on the sick kid. Include them in the conversation. Ask how the siblings are doing. And ask a relative or friend to take a special interest in each of the siblings. Within the school walls, we need to remember about encouraging a normal routine. School can be a safe haven for the siblings, as the siblings can continue their normal routine at school when everything is in upheaval at home. The school personnel has a unique perspective. They are able to observe these kids in their natural learning environment and can be on the lookout for signs of any emotional distress. Recognizing that the parents are super overwhelmed and being as flexible as possible with assignments or deadlines. Again, encourage expression of emotion appropriately. Siblings may feel that their personal identity has now shifted to being known as the brother or sister of a cancer patient. So assisting them to be their own individual and keep their own identity is really important in the school setting. This is a great piece of artwork that's done by one of our patients, Sydney, who is 11 years old, and she and her mom gave me permission to share this with you guys because I kind of feel like this sums up the entire childhood cancer experience. As you can see, she has drawn a person, and on one side of it is the person that doesn't have any hair, has one eye and one mouth. And on the other side, I don't know if you guys can see this, but on the other side it's sprinkled with IV poles, bags of bloods for transfusion, stethoscopes, hospital masks, Band-Aids, needles, IVs. And when I asked her to explain this, she was like, well, you see the person is dark on one side and then gets lighter and lighter on the other side as the things that have to do with chemotherapy and cancer surface. And she said that she calls this me fading into cancer and chemo. So I thought that was really a nice visual image of how an 11-year-old is viewing her life at the time she's going through cancer treatment. So things to remember as we're working with kids with cancer and their siblings. We must recognize that our patients are children with a chronic illness and not a chronically ill patient. They are a child first and a child with cancer second, or a child who has a sibling with cancer second. It's not their whole identity, it's just part of who they are. We might not be able to fix all of these issues that we've discussed, all of these emotions and behaviors and feelings that these kids are having. And it's not our role to fix everything, but it is our responsibility to support the psychosocial, spiritual, academic, cognitive, and social aspects that come along with a kid with a chronic illness or their sibling. Remember that behaviors and thoughts and feelings and emotions have been created in a person over a period of time. They're influenced by a lot of things, by a lot of years and months of past experiences and social situation. And they're not going to change in an instant. There's no magic pill to give or secret word to utter that will make a behavioral change come about instantly. It took a while for our behavior to be created and reinforced and ingrained, and it'll take a while to undo it or to accept it, especially if you're trying to change behavior or help a behavior in the midst of a crisis. Also remember that while behaviors can be changed, personalities, on the other hand, are difficult, if not impossible, to change. We really want to create a space of trust and safety. Allow a person to feel what they are feeling, the anger, the frustration, the sadness, the disconnect that they are feeling. These are very real feelings. And telling kids to not feel a certain way, you shouldn't be angry or you shouldn't be sad, is to disrupt the normal process of working towards acceptance. Telling them to get over it or lucky they survived the cancer is super counterproductive and destructive. Help them find ways that they can safely express themselves. And do not expect a child to return to the kid they were before treatment. Don't ignore the emotional baggage and scars that they are dealing with. I want to thank you guys for your time and thank you for what you do to care for these children and families. And I don't know if we have any questions out there.
We do not have any questions
Okay.
at this time. But
Great.
is there anything else you would like to add to your presentation? We have some time.
I
so if you
don't. I
wanna-
rushed through it faster than I thought I was going to do. It always seems longer in my head, but I do appreciate each and everything that you guys want to do, and I can entertain any questions. If not, we can have another small break.
Okay. Thank you very much, Robin.
Thank you.
Thank you, Robin, for joining us this afternoon and for giving our conference attendees so much good information on understanding the challenges that a child with cancer and their siblings might be facing. If you have any more questions to come up about Robin's presentation, her presenter information is on in your conference resource folder. Our last presenter, Rich Catlett, is the chaplain for our pediatric hematology and oncology families at Children's Hospital of Richmond at VCU. While Rich has been in this position since 2019, the chaplain position was one of the first hospital positions funded by ASK back in the 1980s. Please welcome Rich Catlett.
Hello, everybody. My name is Rich Catlett, like Denise said. I am the chaplain for ASK, and I've been in that role for just under 3 years. I want to give you a little bit of background of who I am. Here we go. All right, so I am a board-certified chaplain. I have been a board-certified chaplain for almost 5 years now. I got my master's in divinity from Campbell University in Bowie's Creek, North Carolina. I am an ordained minister in the Cooperative Baptist Fellowship. I'm going to talk to you a little bit for a second about my experience. So I have been a chaplain on a campus, a group home campus, for kids who've been removed from their home for abuse and neglect and different reasons like that. And also served for about 5 years as a chaplain of a pediatric palliative care and hospice program here in the Richmond area. So I've spent a lot of time working with kids who have been sick, terminally ill, major diseases, and even a lot of trauma in their life. My family, I am happily married to my wife Ann, have been for what will almost be 18 years. I have 2 lovely daughters, Ellison and Embry, who are 13 now and 8. And just want to let you know, please feel free to ask questions throughout this presentation. I feel like I'm trying to hit on things that you all may be encountering, but I wanted to certainly address things that you as teachers experience and have questions about. So please put them in the chat and feel free to ask throughout this presentation. I want to start with a couple of terms that you may or may not be familiar with, and they sort of apply to what we're talking about today, and you'll understand a little bit more as I go through this. So the first term is anticipatory grief. I'm not going to read the definition to you, but I do want to highlight that I starred the terminal diagnosis. Not all of our patients who have been diagnosed with cancer are terminal, of course. In fact, most of them are not because of the advancements in treatment. But when a family hears the word cancer, their mind goes to the most negative of places. And so with that term, cancer or leukemia or something along those lines, our parents automatically can go to worst case scenarios, can think of how this is going to be a really bad situation. They can think about life without their child. And so there's this anticipatory grief that begins fairly early on as they are carrying that weight of diagnosis, not knowing what to expect. And so therefore they're anticipating sometimes the worst. They're anticipating a very difficult and potentially terminal diagnosis. And so they start very early with this feeling of grieving in anticipation of what's next. So this is something that some of our families deal with. Another term, disenfranchised grief. This one is a little bit different. And in fact, what I would say is that there are probably a lot of you out there who are experiencing this yourself. Again, I'm not going to necessarily read the definition, but it's when you're not allowed to grieve socially. There's some examples there, examples such as miscarriage and abortion, suicide, loss of a pet. Some people, for them, they think that that's not as important because it's a pet. Well, for some people, their pet is their child, and so they very much still have that same grief inside of them, but maybe they feel strange really acting on it and emoting to the fullest. Failed businesses, loss of a body part, depression, mental health. So there's things that people are grieving but don't feel like it's socially acceptable to grieve these things. Now, in a lot of instances, our families do talk about their child's diagnosis. They do tell their family, their coworkers, things like that. But there are some families we come across who say, you know what, we're not telling people yet, or you know, and especially in the case of dads, I've come across a lot of dads say, I don't want to talk about it at work because I want to keep work over here and my life is here, and I don't want them to know too much about what's going on over here, and so I'm not really telling. I'm only telling a couple of people. I'm not telling everybody, and so there's this. I'm hiding my grief. I'm hiding my emotions from some people because it's too much, or I don't feel like I can socially talk about these things without breaking down or without getting too into it. And so, and then there's a couple of examples here. Hey, your child's got a good prognosis. You should be happy. Well, okay, good. They're going to survive, but they're going to go through a really trying experience, and this is going to take a real toll on our family. And so it's very much, if people give you good feedback, it's hard to to then share with them more about the realities, the harshness of what's going on in your life. Or, hey, look, you're done with treatment. You know, everything's back to normal now. Well, things will never be back to normal, right? So, and to be able to explain to people that sometimes it's just better off not to. It's just not worth your energy, your voice to explain it. So then you keep that grief inside of you. You keep it to yourself because socially you feel like you can't grieve those things. So those are just a couple of terms that I wanted to start with that, again, maybe not every family and patient is going through, but I think they're helpful because sometimes they're the grief we don't talk about or think about or sometimes even know about are these kind of griefs, anticipatory and disenfranchised. Okay, so we're going to talk a little bit before the child even comes into your classroom after a diagnosis or after treatment. So let's talk about the diagnosis. Just hearing the word cancer at all is very traumatic. It's very traumatic. If any of you have been diagnosed, if anybody you know or love has been diagnosed, you know the weight of that word. And so we should treat kids and families like they've been through trauma because it is a traumatizing word. There's not many words in our life that once they enter them, they don't leave anymore. But the word cancer is one of them. Cancer invokes a lot of fear, a lot of anxiety because we don't know, and we've had people who have died from cancer. There's probably people in your life who you know have died from cancer, and so it's a scary word. And so before they even enter the classroom, know that that word is traumatic on the child and on the family. So our families go through this kind of fog of just uncertainty. They don't always know what's next. They don't know which treatment is going on. They, from day to day, it's just like they're kind of living in this, and it says it on there, like you're in a bad dream you can't wake up from because it's just this haze of, is this reality? Is this real? But you're trying to live day by day and get your kid to the next treatment, the next day, the next pill, the next whatever is on the calendar. Sometimes we tell a family that they have cancer, but we don't have a full diagnosis. We can't tell them exactly. We can't tell them exactly how long treatment's going to last. We can't tell them how much of the cancer we got out with a potential surgery because we think we got it all, but we don't know. Or there's all these things that lack of knowledge presents its own set of anxieties and grief because you want to know that lack of information. And of course, our families are exhausted. I don't know how many of you have stayed overnight in a hospital. I don't know how many of you have spent multiple days in a hospital, but it is an exhausting process. Being there, lack of sleep, something's buzzing all the time, buzzing, beeping. People are coming in and out of your room constantly. You know who some of them are, but a lot of people come in and out and you have no idea who they are. You're trying to remember, you're trying to think, but you're exhausted. Your mind's racing, your mind's going to worst case. And so it's just this really heavy baggage of being in the hospital and taking a real toll on you physically, mentally, emotionally, spiritually, just in so many ways. And you never know how your kid is going to feel from day to day. And that's hard too, because a lot of times parents, their emotions go with their kid. If their kid's having a good day, they're having a good day. But you never know from day to day how your kid's going to feel. They may feel terrible. They may feel good. They may have lots of energy and be good. But they may also be nauseous all day. And that's just a horrible feeling as a parent to be there and not be able to help your child. And that's a lot of pain that they're dealing with in that regard. And then let's get into treatment. Treatment. In fact, in the adult world, sometimes adults opt out of treatment for cancer because they know how bad the treatment can be. From surgery, where we're literally cutting into a child. That's a traumatic thing, whether they're under anesthesia and never know about it or not. I mean, to know that somebody has cut out part of their body. And there's going to be pain afterwards. There's going to be things that they have to deal with afterwards from surgery. Radiation, it's a toxic thing that we are doing to them. In fact, we can only radiate so much sometimes in certain places because it's so toxic. Chemotherapy, we're literally dumping poisons into someone's body. trying to kill all the bad stuff, knowing that we're going to kill good stuff. I mean, it's literally a horrible process. There's a really good book that I read before I started this job called The Emperor of All Maladies. And it traces back the history of cancer from, like, I don't want to say prehistoric, but long time ago, from first documented cases of somebody had like a tumor somewhere, or what they would call a growth or something abnormal. And it would trace how we've treated it, how we've dealt with it since the very first documentation of it. And what you really glean from that book is how those who underwent early cancer treatment should almost be considered like military veterans. They went through hell and through their treatment in order for us to be where we are today, which is to have a better understanding of what we should do here, and then next, and then next, and then following up. And it's a really interesting book, but it also shows you a lot of just how bad treatment can be and how horrific it can be in some cases. And the side effects can be really, really bad. It's almost like we're torturing someone in order to make them better. It's a really hard thing to sometimes even wrap your head around, that we are poisoning someone and almost making them come to the verge of death just in order to make them better. Like, that's a hard concept. Most medicines don't work that way, but that's how we treat cancer. Okay, so by the time the child reaches your classroom, they've been completely traumatized. They've had a number of losses, and they are grieving heavily. And to me, one of the biggest things that families and patients grieve is that they'll never go back to quote-unquote normal. They'll never go back to the day before they were diagnosed with cancer. And that is heavy. That is hard to know that you're never going to be the same kid again. You're never going to have the same family again. Things are always going to be different. That word cancer will always and forever be in the back of their mind. Even if a doctor says, hey, we've cured you, you're treated, there's no signs of cancer, there will always be that word cancer in the back of your mind, that it could come back, that you could relapse. And so once that word enters a family's vocabulary, there is no going back from that. There is no going back to the previous way of life, which is their normal. And so that's a heavy, heavy loss, that we're never going to be the way we were again as a family before this. And so just know that is a tremendous grief that families and patients carry with them into the classroom. Okay. So what we're really talking about that happens to families in this process is trauma. Trauma is, the definition, I will actually read this one. Individual trauma results from an event, series of events, circumstances that is experienced individually as physically or emotionally harmful or life-threatening, that has lasting adverse effects on the individual's functioning, mental, physical, social, emotional, or spiritual well-being. So trauma forever can change who a person is. Like, think about that. A trauma of a diagnosis, of going through cancer, of having something major like this happening, will forever be imprinted on a person. If you know anything about the ACE study that was done a long time ago, ACE stands for Adverse Childhood Experiences. They did some testing, and the more adverse childhood experiences, meaning trauma essentially that happened in someone's childhood, the worse their health was later in life. The more they were potentially alcoholics or smokers or had all these negative health outcomes because of trauma that happened in their childhood. So we know that the weight of trauma isn't just in the moment or isn't just in those years, but it can forever imprint on a child into their lasting life, into adulthood. And so we, we should approach these young people, these families, with a trauma-informed approach where we anticipate that there's trauma, where we anticipate that there has been something significant that has imprinted on them in such a way that they will never quite be the same. but it doesn't mean they can't overcome it. It just means that they have something very difficult that they have gone through. So let's talk about some of the losses for the child who is undergoing cancer treatment. So, of course, depending on their course of treatment, there are going to be some physical limitations. We've had some kids who've had to have amputations. We've had some kids who've had to have, radiation to certain parts of their brain. And so these things have tremendous impacts on what they are some of their abilities, what they can do mentally, cognitively, how they can concentrate, can they remember things. One thing that I see every day is just the change in appetite and taste. We so often are encouraging our kids to eat, and so often they don't want to. Some of it is they're nauseous, but some of it is things just don't taste the same anymore. And so when they come into your classroom, they may not like that peanut butter and jelly sandwich that they've eaten every day for the last 10 years. It may not taste the same to them anymore. Recently, I had a young man whose dad was trying to leave the hospital. He was trying to go do something. He was in a rush, and I could tell. And he's like, man, I got to get downstairs, and blah, blah, blah. And I'm like, what's going on? He's like, I just got to get him some water before I leave. I got to get him some bottled water because he can't drink the water in the room anymore. It just tastes too bad to him. Like water tasted too bad to him. And so he could only really have the bottled water. That's the only thing that tasted normal to him. A big loss is independence. Gosh, you guys know more than anybody how much kids want their independence. If you have kids of your own, you know how badly they want independence. And so if they now become dependent on someone else, if they now have to rely on other people, if they now cannot do the things that they used to do, they're no longer able to strive for that independence like they used to. And that's hard, because that's part of growing up. That's part of becoming an older child, becoming an adolescent, becoming a teenager, becoming a young adult, is to make those steps to full independence. And so if we have something that's really limiting that, that's a major loss on a child. They may have really lost out on a lot of their socialization opportunities. They may not have the same friends. They may not have any friends. When a kid's going through cancer treatment, they become immunocompromised. We strip down their immune system to a point where any small infection, any small germ can have a major impact on them and potentially hospitalize them and make them in a very bad place. And so we try to tell families to limit socialization outside of the circle of their family. And so kids who used to go outside and play every day with their next door neighbor can't do that anymore. Kids who used to have play dates all the time can't do that anymore. And because of that, because of living in that bubble for however long a period of time that is, kids now don't know how to socialize like they did before. And so having friends, knowing how to be a friend, knowing how to socialize like you used to becomes a lot harder. And so sometimes kids isolate. They don't know how to engage with their peers like they used to. There's a loss of some of their family relationships, the stability within them. So this going through cancer treatment can be really hard on a family. And where it takes a toll is almost every relationship within the family, whether it's mom and dad, whether it's sibling to sibling, whether it's parent to child. All those relationships become strained, and because of that, a child can feel like there's less stability in their home because those relationships aren't as nurturing or as comforting or as present as they used to be. If there's a parent who now has to work all the time because they're the provider for the family, they may not see that parent as much as they used to. And so that stability is something that they lose pretty quickly sometimes. So that goes into the security. Sometimes, depending on the age of a child, a parent will want to wait before they tell a child what their diagnosis is. We try to discourage that sometimes because we know that kids are smart. We know that they pick up on things. We know that they know that something's wrong. And so we try to say, be honest with your child, be honest with what's going on as much as you can. And so if a family is keeping something from their child or from their siblings, that's like a loss, because the child picks up on that. And so then the trust begins to break down, and that can have a really detrimental impact on the relationship. Conflict resolution. Does a child who hasn't had contact with another child in a year know how to have conflict resolution with another child when things happen? Those kind of things can certainly change. Self-control and self-regulation. So sometimes their body doesn't respond like it used to, and so they can have some emotional outbursts. They can wet their pants when they didn't used to do that. They may be at an age well beyond that, but because of certain changes and certain things that have happened, they can't regulate their body like they used to. And so the child now has lost a lot of what they could do before, and that is a huge loss, because it's almost like they've digressed. Some kids, unfortunately, lose some empathy and compassion. When they go through treatment, sometimes they become the center of the world for their family or the people around them. And when that happens, they can become very self-centered. They can become very much focused on just themselves. And so they don't always have the ability to think of others when life has been only about them, only about their illness, only about what they're going through. And so they can lose a little bit of that empathy and compassion. They may not be able to do the same hobbies and sports like they used to because of some of those limitations. They may have some really poor performance in school. They may not have any desire to go to school. They may just be struggling in general with wanting to go to school at all, when they may have loved school in the past. And some of it is, if they miss enough time, if there's a lot of things they have to catch up on, it can become this mountain that they feel like they now have to overcome. I've missed so much of this. The stacks and stacks of work I have to do to get caught up is so overwhelming that I can't even begin to take that first step of achieving that. And so that academic drive may go right out the window, because it seems like a mountain. It seems like something I can't do. It seems like something that's just easier to give up on. And so, be empathetic to that for them, that they are going through a huge change, and that while kids want to learn and grow, they can also be overwhelmed by that thought and that huge obstacle that it seems like it's in front of them. They are grieving a healthy body that responds like it used to. Their body may not be able to do the same things that it did before. Their mind may not be able to do the same things that it did before. And so that response that they always knew they could do, they might not be able to do that anymore. And that's really heartbreaking to them. They may give up on some of their passions. They may be tired all the time because they're not sleeping well, or maybe they're sleeping too much, or they're, the medicines they're on. And really, more than anything, they're grieving normalcy. They're grieving the way things were. They're grieving feeling good and just being a kid. They're grieving that pain of not being who they were before all of this. And so that's a really, really heavy thing for them. Okay, we are on a really heavy topic, and this is a lot. And some of you may be nodding off. Some of you may be even tearing up. Some of you may be having a hard time. So this is my intermission breakup / dad joke / teacher joke time for you all. And I'm going off script here. So all you back there, don't freak out. I'm going to make sure that we get back on track. But I feel like I got to break this up a little bit. It's a little too much. So I'm going to just generally ask y'all a few jokes. What do you call an acid with an attitude? Amino acid. On the first day of school, what did the teacher say were her 3 favorite words? June, July, and August. Except for you year-round teachers. Sorry about that. Who's the king of all the classroom? The ruler. If April showers bring May flowers, what do May flowers bring? Pilgrims. The Mayflower. Get it? All right. What did the pencil sharpener say to the pencil? Stop going in circles and get to the point. And my last one. Why was the geometry book so adorable? It had acute angles. Oh, so adorable. All right, so we're talking about loss and grief. I had to break it up a little bit because you guys are probably nodding off. All right, so let's get back to the heavy stuff. Okay, so these are some behaviors you may see from the child in the classroom, and these are associated with the losses that we just talked about, right? They may be trying to assert that independence because, again, every child is striving for becoming more and more independent. So if they have that total dependence or they feel like they can't do anything on their own, they are going to try to assert that independence when and where they can. They may have a neglect in their appearance, or they may go the opposite route. They may have hypervigilance, like make sure every hair is in place because that's the one thing they can control. So things like that. We talked about they may have some real anger, some outbursts. They may just start crying out of nowhere. They may start isolating. They may seem distant, numb to things. They may not be, when every other kid in the classroom is laughing, they may just be kind of in their own little world. And depending on their age, they may not be able to verbalize any of this. They may not be able to verbalize any of these feelings that they're having. And that's really hard for them because, and it's hard for you as the teacher because you can ask them what's going on, what's wrong. And they may not be able to put into words why they're feeling what they're feeling. They may not be able to verbalize it at all. They may not have the vocabulary for it. And small things may just completely set them off. Having a small setback can all of a sudden make them just lose it. And it's kind of, again, that grief of, I can't do the things I used to do. I'm not the same person anymore. My body's not responding the same way. My mind is not responding the same way. And so those small setbacks are a reminder that I have lost something. I am not the same person. And so they may have really strong reactions to that. You may notice that they have darker, and when I say darker, I don't mean black, but even though there could be black, I mean darker as in kind of more negative, more scary kind of artwork. They may be drawn to darker kind of music. I remember this one young man he was doing music therapy with this music therapist, and he kept being drawn to this one song that just had a lot of really darkness in it, really negative stuff in it. But it's how he was feeling, and it's what he was going through. I mean, he ended up having a terminal diagnosis, and so his response in doing music therapy was being drawn to artists and to musicians and to songs that went with what he was feeling. He could relate to the darkness of the music because that's exactly what he was feeling. They may be more nervous or anxious than they were before. They may have a lot of fatigue, especially if they're trying to keep up with their peers. Again, if they've had setbacks, if they're limited in some way, and everybody's running around the schoolyard, everybody else is playing tag, everybody else is playing kickball, everybody else is doing this or that, they're going to try to keep up. They may not be able to, and so they may get tired easier and quicker, which may again lead to the emotional outbursts, which again are due to the fact that they are not who they were before. And here's a reminder that kids grieve in spurts. So we as adults tend to grieve over a longer spell. You tend to know sometimes with adults when they're grieving. We show it a little bit more. We can use our words to say it. But the intensity of grief can be so much for a kid that they can only grieve in spurts. They can only grieve in small bursts, which is why they may be completely happy all day, and then all of a sudden, bam, they're crying. They've lost it. They're done, and you may have no idea why. And maybe they tell you, I'm really sad because I can't do this anymore. Or I'm really sad because I don't have any hair right now, or I'm really sad because, my friend, I can't see them anymore because my mom says that, it's not safe. And so you hear it, and then they may go right back to being happy again, because kids tend to grieve in spurts. They tend to grieve in shorter bursts and spells. And so just, know that that's a very different thing from how adults grieve. Okay, so let's talk a minute for the family as a whole, some of the losses that they have. We talked about this a little bit, the healthy family dynamics or relationships that they had before may have changed. Because of, again, the treatment where a child may have to be more isolated, where they can't go out in public, where they can't do the same things, they can't be around other kids, a bubble kind of forms around the family. They kind of live in this bubble, and they don't let many people into it. And so it's really hard when you're relying on just the people within your bubble for support and for compassion and for empathy when you're all tired and exhausted and going through heavy stuff. So sometimes those relationships break down. Sometimes let's just give an example. Let's say dad is working all the time. Mom was working, but she may have had to quit her job so that she could take the child to and from appointments for hospitalizations. Mom and dad can sometimes be like ships passing in the night. They may not spend much time really talking about things. Mom is getting all the medical information, whether she wants it or not. She's hearing from every doctor, from the nurses, from everybody else as to what's going on. Dad feels like he's in the dark because he gets a secondhand account from mom, who's exhausted and who can't remember everything that the doctor said. And so then there's this frustration in how they're communicating or whether they're communicating, who has the info, who doesn't, who has to pick up the other kids from practice, who has to get dinner ready, all these things. And so the relationships can begin to really, really be stressed and strained to a point where people just feel isolated and overwhelmed. And they're lonely and they're tired. And that's where relationships can really break down. And because they're living in that bubble, because their child is immunocompromised, they can lose a lot of connections to family, to their outside family, to their community, to their social networks. It could be that a family would go to church all the time, but now they can't go there anymore because their child can't be around other people. So what was a really strong support system for the family is now no longer available because they can't go anymore. Things like that, where they just have lost a connection to the outside world, and that is a huge grieving time because you don't have that when you really need it the most. And of course, this takes a huge strain on the family financially. Bills pile up. They get medical bills. They get all kinds of bills. And again, if one of the parents has to stop working, you just cut the income in half, or you just, cut out a huge chunk of what the family was using to survive on. And so now they are not as secure. They don't feel as secure as they were before, because how are we going to make ends meet? How are we going to pay all these bills? How are we going to get through this? How are we going to just, do the little things that we have planned? And not to mention planning for the future, the things that are going to cost money down the road when you can barely make things happen right now. For some families, there's a real tangible loss of joy and happiness. Anxiety takes over sometimes. Stress takes over. They're so worried about their child's health that, again, they push others away. They isolate. And so when you're isolated, it's harder to find joy and happiness when you're completely on your own, when you're just getting by, when you're surviving. Joy and happiness come in thriving, not in surviving. Surviving is survival mode is what a lot of our families go through during treatment. And so to have joy and happiness when you are exhausted and when you're going through the worst time, it's hard to find those times. And so there's a real, even grieving over that. Like I miss going out with my friends and having a drink and laughing and being stupid because I can't do that anymore. Communication and intimacy. We talked about that with the relationships, but there can be a real breakdown in intimacy, especially between mom and dad. There can be even intimacy breakdowns in ways where things used to be, right? If somebody used to put their kids to bed every night and snuggle with them and love on them, they may be too exhausted. They may just be doing just enough to get them in bed and say goodnight and turn the light off. And so some of that intimacy and closeness can be lost as well. Hopes and dreams for the future. Again, when you have a child, you can begin to imagine what their future might look like, what their interests are, what their long-term career is going to be, who they might marry. And again, when the word cancer enters into the equation, that those other things can kind of take a step backwards, and you can't imagine those things like you used to. Faith, religion, and spirituality. I talk to people about this all the time. So sometimes when a family goes through cancer treatment, there becomes a lot of asking why. Why us? There's this feeling of, I must have done something wrong. I'm getting punished. And of course, they're kind of saying it in a divine way, like God is punishing me. And they say it because I've done some bad things in my past. And so where I say your beliefs and your reality aren't in line. So if my belief is that God is good, God does good things for me, but your reality is everything that is bad that could be happening is happening, those two things don't really line up. And so we talk about how to make your beliefs and your reality line up a little bit more. If you believe in a God that is just is punishing people because of the bad things they do, okay, but that's not necessarily how things are. And so we talk about, okay, so what are your beliefs about God? Have your beliefs about God changed? Do you even still believe in a God, right? Because if you believe in a God, if you believe in a good God, but nothing good is happening to you, it can be really hard to connect with anything beyond yourself. You're, again, in survival mode. And in survival mode, some people turn to faith and religion. Some people pray. Some people do these things. But for some people, they turn internally because they say there's nothing out there. They say that there's nothing. If there was something out there, it would be helping me right now. It would be making life better. It wouldn't be allowing my child to be sick. And so there's this loss of reconciling the way you thought about the world before and how you're thinking about the world now. What you're thinking about faith and religion, whether you believe in it at all, that's now something that you are kind of grieving because you now have to maybe think about it when you didn't have to think about it before. You now have to say, well, maybe everything I grew up believing isn't true. Maybe everything, I have to question everything now. And that's okay. But with that comes, a grieving process of maybe giving up on some things that were a part of your life before. The loss of safe spaces and safe people who truly understand. One of the most heartbreaking things that I hear from families is when they say, you know what, I really can't talk to, and this is a parent talking, I can't talk to my parent. I can't talk to the child's grandparent about these things because they're not helpful. They don't understand. When I talk about it, they become almost critical, like, why aren't you doing this? Why aren't you doing that? Why aren't you doing this? And so what ends up happening is that bubble shrinks even more because sometimes the people who they're closest with, sometimes their best friends, their family members don't get it and don't understand, and that is really, really hard. It's why a lot of families really rely heavily on our medical team, on people like me, on people like Robin, because we understand what they're going through. We get that life, and unfortunately we get it and understand it where other people don't. And so they're grieving safe spaces where they can be open and honest about how they're feeling and what they're going through, because sometimes they can't do it with the people that they used to be able to do it with in the past. Other behaviors you may experience from the family: poor communication. They may not get back to you. They may not follow through with anything you're asking them to do. They may be so overwhelmed that they're not checking any of their emails, they're not checking their messages, and so you may have communicated with them, hey, your child has not turned in this assignment in a long time, or this child hasn't been in school in a while, what's going on? And you may not hear from them. They're sometimes so overwhelmed that they don't know how to even have minimal communication with people around things. And so just know that that's sometimes more the circumstance than the person. This one's a hard one too. They don't tell their child no anymore. If there's a kid in your class who is going through this, unfortunately, they may have become the brat in the classroom. It's not always the case, but sometimes our kids hear a lot more yeses than nos when they go through this. I heard a mom say, I just can't tell him no anymore, because he's got cancer. And it's like, okay. And so what ends up happening is this child becomes a bit of a brat because they think the world revolves around them. We talked about this with their lack of empathy and their lack of feeling for others. And it's because maybe, their family is telling them that they're the most important person, they're the most important thing, and we don't tell you no anymore. We give you everything you want, everything you ask for. And it creates a little bit of a monster sometimes. And so just be aware that parents struggle a great deal with how to be a good parent while their child is going through something that is really devastating. The family may have a lot of anger. They may take it out on you. They may lash out at you. Those emotional outbursts, they may be late to everything. The kid may be late to school every day. The family may be late to every appointment that they have. And some of it is because, again, they're in survival mode. And in survival mode, you're lucky if you get there, I remember early on as a parent, there were days when I had my kids just me with the baby. And when my wife got home, I'm like, hey, they're still alive. They're fed. That's about as good as it's going to be for today. If they're wearing clean clothes, that's a bonus, right? If their hair's brushed, that's a bonus. So when you're in that survival mode of this is all hard, this is all a lot, I don't know exactly what I'm doing, sometimes just getting through life is all you can do. And so those other things go to the wayside, and school will be something. Sometimes it does that. Some families don't put a huge priority on education. They didn't to begin with. And so when this happens, they're really not going to put a priority on school. And even families that did have a priority on school before, sometimes they just say, this isn't the priority right now. My child's health is number one. My child being healthy is the most important thing. And so this is what we have to do. They can get back into school later. They can get caught up later. But right now, them getting through this is the most important thing. Okay. So something both child and parents struggle with. This is such a hard one. Is guilt. And so much of it is unfounded guilt, right? The child is the sick one. And so sometimes they feel guilty because, well, I must have done something to make myself sick. I'm sick. The family's having a hard time. My mom is always crying. My dad's always stressed, and it's because I'm sick. So it's my fault. So a child is dealing with a lot of guilt, whether there's any need for guilt or not. And the same thing with a parent. Once again, if you're a parent, when you have your child, you feel responsible for them every day, every moment. And so if something happens to them, when my kid falls off their bike in the street, I feel guilty. I guess I should have been there to catch them, right? And so we as parents sometimes can just take on guilt because that's our default. And so parents will automatically go to a point where they feel guilty about what's happening to their child, even though they had nothing to do with it. They did not cause their child to be sick. They did not cause this to happen, right? And so getting families to acknowledge that it's not their fault, it's nobody's fault. Life happens sometimes, and life sucks sometimes, and it's rough, and it's terrible. But it doesn't mean you did something wrong. It doesn't mean you're being punished. It doesn't mean that you know, you're a bad person in any way. And so this is something you will see with, again, with child and parents, that they live with a lot of guilt, and that's a loss too, because if you're going through life not feeling guilty and now all of a sudden you're always feeling guilty, you've lost that peace in your life. You've lost that status quo of things being okay, things being good. But now that guilt has really entered into your world, there's a heavy weight of loss that goes with that too. Okay. Now, what you can do to support. So this first one is a little bit hard. Be consistent and have the same rules for everyone. You know, because the child wants to fit in, because they want to be like their peers, they don't necessarily want to be singled out. But at the same time, they have something rare and different. And so it's hard to balance that. We want to treat everybody the same and have the same rules, but also acknowledge that this particular person in our classroom is having a hard time. So it's being able to talk about it without making them the victim, because we don't want them to be stuck in a victim place. We don't want them to feel like they are a victim to their circumstances. We want them to become resilient. We want them to get through this and overcome this. So being consistent, having those rules for everybody, while also acknowledging that, hey, Jimmy, we're going to give him an extra minute here because we want him to catch up, or we want him to do this. And so that's a hard thing to balance. Lead with empathy. I know you all have a ton on your plate. Having 2 daughters in the public school system, I know how hard you all are working. I know how difficult it can be right now with parents putting demands on you. One parent telling you that they want something and another parent saying almost the exact opposite, and how do you balance those things? And so to be able to lead with empathy every day is a hard thing, but it's one of the things that makes you amazing at your job, makes you a great teacher. And so the more you can start with empathy for what a family or a child is going through, the further that'll get you into helping them with that grief and with those losses that they're coming with every day. Create and celebrate moments of joy. You know, we try to do that a lot with the young kids that we work with, is to celebrate when they're overcoming, they're doing things on their own, and they're getting back to a sense of normalcy. They're getting back to walking and going to school and things. And so when you have moments, celebrate them. You know, when that young person does something that they didn't think they could do, celebrate it. You know, be happy. Get everybody to be happy about it. Teach them to give back. So often when I talk to, I do bereavement as well in my role, and so sometimes I'll talk to parents who have lost a child, and one of the things I try to talk to them about is giving back, because it's so easy to get stuck in your situation and in your sadness and in your pain that you don't venture out beyond it. But one of the things I encourage people to do is to give back. Sometimes it's just buying a coffee for the person behind you in line. I had a mom the other day who I was talking with, a bereavement mom, and she was telling me how she was at like a Starbucks one day, and she saw this mom that just seemed overwhelmed and was struggling. I had a child with her, and she just went up to her and she's like, you know what? You're doing the best you can, and I see that, and you just keep going and doing you. You've got this. And the mom broke down and was like, you don't know how much I need to hear that. And she got so emotional. And I reminded that mom, who was grieving, literally grieving within the last year of her child dying, that her kind words made such a huge difference in the life of this other mom. But that mom also affirmed to her how much she needed to hear those kind words, and that in itself affirmed that bereavement mom, and it helped her to know that life still goes on, and that I still have value to give to this world. I still have love to share. Even though I don't share it with my child anymore in tangible ways, I can share that love in other ways. And so when you're grieving and when you're going through loss and hard times, sometimes the thing that helps you move beyond it is doing something for somebody else. And that seems counterintuitive, but the reality is, if you do it, you will know that it makes a huge difference in moving forward in your grief. And I know you all are already doing this, but let the child know they are safe and they are loved. That when they are with you, you care about them no matter what their limitations are. You believe in them and what they can do no matter how bad a day they had. That you know that they can achieve great things and get beyond where they are right now. Like, that love and support is what's going to help them become more resilient and get beyond where they are in their cancer journey. And again, that praise for being resilient. The one thing the more you learn about trauma and childhood trauma, the thing that helps have better outcomes is resilience. Teaching a child how to be resilient, teaching them how to overcome and not become victims and stuck. It's so easy to get stuck in the negativity, to get stuck in the I can't do this, and stuck in the my body won't let me do this, or I can't do this, or woe is me, and stuck in those bad places. Is resilience, to overcome. Sometimes just doing little things to help overcome. To praise a kid for doing the most minimal thing may help them take a bigger step in doing something that they didn't think they could do. And so praising them, giving them affirmations, teaching that resilience, that's one of the greatest things that you as a teacher can do for a child who has lost so much because of cancer, is to teach them resilience, to teach them how to overcome. That is one of the greatest gifts that you can possibly teach and educate them around. Let's see. Okay, and again, what you can do to support them for the family is to help them connect to the community, remind them that there's support out there, that they don't have to do these things alone. Sometimes you have a connection and do those things, but sometimes you need to remind them that there are other people in the world that will be there for them and support them. Organizations like ASK, that's really a lot of kind of what we do, is remind families that there is still a community that really cares about you, and that's important for you to plug into, because we know how much having relationships outside of just your immediate family, what that can do to help normalize things and help them become resilient, to help them move beyond where they are into a more positive place, to go from that negative, difficult place into a more positive place. We need people in our lives. We need community. We were created in community. We were created, and we have to coexist with others. And in a lot of ways, that's what stimulates us to be our best. Again, that empathy, communicating with compassion. When you have a parent who is a terrible communicator and who isn't following through, can you still be compassionate? Can you still be empathetic? Can you still communicate with them in a way that shows, I care about you, even if what you're doing is driving me crazy? Even if what I've asked you or your child to do 100 times, you won't do it. I'm still going to try to be compassionate for you right now, because that's what you need. Be that encourager. Be patient with them. Let them know that you are there, that you care about their child, that you believe in their child. Those are such important things. And to end on a more positive note, kids are resilient. Man, they're so resilient. They give me hope. My kids give me hope. To see what they can overcome, to see what they don't let get to them. We had this young man who recently had an amputation. He had to have an amputation, kind of below the knee. And to see how he has adapted to that is inspiring. We as adults, if that would have happened to one of us, we'd just be like laying in bed all day. Oh, it'll never be the same. Right? And this child is like, okay, if this is what I got to do, this is what I'll do. And yeah, I might not be able to do this over here, but you know, I'm not gonna let this dictate my life. I'm not gonna let this change everything that I do or keep me away from doing the things I really want to do. Kids are resilient. They can adapt and change. They can adapt so much quicker than we adults can. And so that's what gives me hope working in this field, is to see how kids can overcome when we as adults can get really stuck in the negative. Kids can overcome and be so much of a positive influence on us and our community. Their stories impact our community greatly. We just had our yearly gala for Ask, and one of the key things that we focused on was one patient and her story, and how she got through it, and how she has come out on the other side, and how it's changed her family. And that story is just so impactful. You know, to hear it coming out of the mouth of a child, or to come out of a parent's mouth, as to how difficult it was, but how they've gotten through it and how it's changed them. Man, it's inspiring. It's amazing. And so just know that when you pour into kids like this, you're pouring into not just the present, but the future of who they're going to impact one day, and who they're going to maybe influence for the better because of their story. And that there's still a kid in there, right? Even though they're dealing with adult issues, even though they're dealing with cancer in the medical field and all these things that are like, grandma should be dealing with this, not the grandchild, right? And so for them to be dealing with adult stuff, there's still a kid in there, and there's still joy and happiness in there, and to let them have times when it's just they can be a kid again, and to remember that overcoming cancer is a major accomplishment. It really is. You know, this kid will have a bit of a badge of honor with them for the rest of their life, and it's something that you can celebrate with them. And their story really, really can change the world. But thank you for what you do. I really appreciate it greatly. I know a lot of teachers personally, and I love every one of them and admire them. I volunteer at my daughter's school because, I want us to keep good teachers. And so I appreciate what you do and how you unconditionally care for kids. So, Denise, do we have any questions or any?
There are no questions.
No questions?
No questions.
Y'all are all asleep, aren't you? That's fine. I get it. It's after lunch. It's talking about grief. It's boring. I ran out of jokes. I should have got more jokes, I guess, right? But thank you. Thank you for being a part of this. Thank you for taking the time to learn about how to best help these families and these kids during this really difficult time in their life, and just loving on them and helping them become more resilient. So thank you.
Thank you, Rich.
Yeah.
Thank you, Rich, for joining us this afternoon and for helping our attendees understand what grief and loss might look like in their schools and classrooms. If any more questions come up after today's presentation, Rich's contact information is on the presenter information page in your conference resource folder. As I said earlier, if you didn't have a chance to take one or all of the post-presentation surveys, there will be links sent to you after this conference. You must complete both the pre-conference and all of the post-presentation surveys in order to receive your CNEs or CEUs. The last item on our agenda is a pre-recorded panel discussion with Emma Morgan and a few of our childhood cancer survivors and parents. We can give you facts and figures all day, but their stories are the best way for us to show you how your efforts and actions can really help our kids when they go back to school. Please enjoy hearing their conversation.
Good afternoon, ladies. Thank you for being a part of our panel this evening for our Educators Conference. Each of you, you're the experts today. I know that our participants in the Educators Conference, they've heard from lots of professionals about the overview of childhood cancer and late effects of treatment, the social needs of children with cancer, vocational and educational needs. But you are the experts. You've walked the walk, you've lived it, you know what worked, you know the challenges that your child had and or might still have. You know the interventions that have been put in place that have been beneficial. So we want you to help educate our teachers today. So before we start, let's go around and I'd like for you to introduce yourself. You may want to state your name, the age of your child at the time of diagnosis, and maybe the diagnosis of your child, and then how old they are today. So who would like to start first?
I'll start. I'm Elizabeth Stebbins, mom to Sophie. She was diagnosed with acute lymphoblastic leukemia on March 3rd, 2013, and that was 28 days before her third birthday. Come over here. There she is.
Hi, Sophie.
Hello. Okay. She's a mini-me.
Absolutely.
Mm-hmm.
Next.
Okay, I'll go ahead. My name is Erin Pullman, and my son Landon was 5 weeks old when we found out he had stage 2 neuroblastoma. He is now 12 years old. He'll be 13 in June. He is currently running outside and playing on the trampoline with his younger brother and his friends, and he's doing really, really great.
Right.
I'll go next. I'm Courtney Townsend, and I am currently 23 years old. I was diagnosed with Hodgkin's lymphoma when I was 15, and I'm getting married in 2 weeks. So, under 2 weeks. So I've came this far.
That's wonderful.
I'll go. My name is Samantha. Mom to Haley. She was 15 months when she was diagnosed with stage 1 neuroblastoma, as well as opsoclonus myoclonus syndrome. She will be 15 in September, and she is just flourishing, especially the past couple years. So she's doing really well.
Great.
I'm Shondice. How y'all doing? I'm the mother of Troy. Troy was diagnosed with acute lymphoblastic leukemia in 2010. He was 2.5 years old. He's now 14 years old, Christmas baby. Little complications here and there, but he's nice and healthy. Troy wants to say hi. Come here, say hi.
Hey. Hi, Troy. That was a quick entrance there.
I know, right? Come back so she can see you, Troy. Miss Morgan saying hi.
Hi, you look great.
Say thank you.
Thank you.
All right. I got it.
Well, I think now that we'll just dive into some questions that we have for you that will help you tell your stories. As I said, you are the expert. So, Samantha, I think I'm going to start with you if that's okay. You know, Haley was diagnosed with neuroblastoma at the age of 15 months.
Yeah.
It's my understanding at that time she lost the ability to walk and to talk, and she had to learn these skills over. Can you talk about the support services that she needed along the way to get her where she is today?
Haley required a lot of early intervention we did speech therapy, occupational therapy, and physical therapy. And then as she, grew out of that, we had to go into facilities and still continue a lot of those to work on just the basic skills of being able to pick up a spoon again, or a crown, or even just hold a cup, to walking and waving and just being able to take her first steps again.
I know that I've been with you through lots of school meetings along the way, and trying to find that appropriate placement for her. What do you think has been the greatest challenges that you've faced?
The greatest challenges have been, as a parent and helping her along the way, is letting go of those, I guess, not expectations, letting go of the ideas of that she has to do it a certain way to succeed. Finding Haley's way for Haley's success has been like the hardest challenge, to be able to find the best tools and ways for her to succeed to her best abilities, and finding where school fits in with that and helping her along the way has probably been the best, the hardest challenge is not the best. I'm sorry.
But meaning that everybody has different developmental milestones, and that letting her develop hers when she was ready, and using school personnel to help guide you in that direction.
Definitely, yeah.
Well, Haley is one that comes out and participates in our middle school, high school retreats for Ask Childhood Cancer Foundation. And so it's been now at 14, it's just so enlightening to see how much she has grown and how much she has progressed. Can you tell us a little about this past year and, the past 2 years, and getting her involved in regards to her social skills and her socialization with her peers and participating, much like the typical child in school, participating in clubs and organizations?
Yeah. Especially the past 2 years, having those different interactions, both in the school and outside of school, she's been able to learn to develop those social skills to communicate, because communication is something you carry around every aspect of your life. Like, she's going to have to know how to do that no matter where she is. And being able to work with different, kids on different levels, it's really widened the way that she is able to communicate on so many different ways. Like, she can pick up those social cues. Like, if somebody doesn't understand her because her speech is still severely delayed, she can understand, okay, they're not understanding me. How can I take a moment to help them, like help both people get to the end result and be able to communicate and enjoy those sports and those games together. And I think she's done a really well job. Like, she really loves Gaga ball. That was one of her favorite things at the retreats is being able to play that with other kids, and learning to take a moment to help them understand her a little bit better, so everybody's really involved.
Tell me a little about, you said something to me on the phone recently about some cooking classes or clubs at school that she is now participating in.
She's now able to participate in after school programs, which, years ago we probably, we thought, are we going to reach this? But we've been able to reach it together with the help of Ask, all the different retreats that she's been able to be a part of. Now she can stay after school and enjoy those cooking classes, which we never thought, oh my gosh, she loves cooking. Drama, she loves drama club, which, she's developed a little bit of sassiness with that now, but it's great to be able to see her enjoy those things that at times felt a little bit out of reach. She's really loving it.
It does my heart good to hear this also, because I know that in those younger elementary years, and we talked a lot, and we were always almost grasping at straws to find that perfect placement for her. And these children, in some regards, and I can say at 14 now, when I look at Haley, and as you said, her understanding of other peers and helping them understand her, they sometimes have a maturity about them that other children don't have. So in regards, even no matter what their disability might be, they might have some challenges due to, their disability, but at the same time, a lot of them have that emotional or that maturity about them that other children do not have. So thank you, Samantha, for sharing. For someone who had to learn all their skills over, I think we have so much to be grateful for. So thank you so much for sharing that today. Ms. Thompson.
Yes.
Troy was diagnosed, I know, at 2 with ALL, leukemia.
Yes.
And in regards to school, even though he was diagnosed really young, he got through those elementary years pretty easily with few problems. It was almost closer to middle school and all that you contacted me, and you said that you thought he probably needed a 504 plan. Can you discuss some of the challenges that Troy was having that, kind of tweaked your interest and your concern about this 504 plan and getting him some accommodations in the school setting?
I first started noticing it when the phone calls started coming, from certain teachers calling, Troy did this today or Troy did that today. And I started noticing the drop in the grades. So when I started seeing those, I was having conversations with a couple of his teachers, and I was asking them, what was some of his issues. He wasn't finishing work on time. It was like he was getting, like a little agitated, like when teachers talk to him. It's like he was becoming, it's like he wasn't having time to do a lot of stuff. It's like he was just a little delayed. He was getting a little delayed. So when I reached out to do the 504 plan, I was trying to tell them, I explained to Ms. Morgan, about the grades, what was going on, the issues that I was having. And sometimes when you're talking to the teachers, I try to tell the teachers, look, Troy's been through this, this, and this. And sometimes it might not affect him then, but it affects him in the long run. And me, like I said, I was monitoring his grades, monitoring his, his attitudes. It's like he get, even like during school, like if the teacher says something, it was like he get a little antsy or get a little frustrated, and that was my whole issue. I said, okay, I need to try to see if I can get a little help here. So with the 504 plan, what that helped me was like, if he needed more time, he was given time. If he needed to take a time out, he was able to take that time out. With the 504 plan, they monitor, his work progress. So with the 504 plan and me with the teachers, it really, to me, I got a rapport. The teachers, I was able to talk to the teachers more. If he do this, do that, y'all call me. Don't just send it, just send it to the office. There was a lot of stuff, in that area.
I think when we first started talking, I remember, and we talk about this in our survivorship clinic. We talk about the late effects of treatment and the cognitive late effects. And one of the main ones that we see is the processing speed. And I think, if a teacher asked a question in the classroom and then Troy wants to answer the question, somebody else, because he's taking time to process what is being asked and how he's going to respond. So somebody blurts the answer out, or he feels like he doesn't have time to respond. And when he was completing his work, it was taking him so long, I think, to get, because of the processing speed, to get the work completed, that it becomes frustrating sometimes. So if you're each class, you're falling further and further behind, which sometimes means that you have more homework at night. So that's why you need the modified workload with emphasis on the quality versus the quantity. Or when you're taking a test, you might need time and a half or double time. That's going to benefit him a lot when he starts taking the PSATs and the SATs, that he'll get that extended time. I know that Troy has been playing football for a long time, and that is his number one love, I would say. Do you agree with that?
Yes, I do. That's his go-to. That's his heart. He loves football. You even to the point, he watches on TV. He can give you the stats. He loves football. And here recently, but the beginning of the season, Troy had an injury. And the injury to me, like I was explaining to Miss Morgan, he fell and he broke his hip. It was during a practice drill. And to me, with the break of his hip, when I say fall, it wasn't like a real hard fall, but he fell and his hip just cracked just like that. And as far as like treatment, to me, I felt as though, like when they're doing chemo and stuff, that's one of the late effects, the bones, so it took him a while to heal. This was in August, and he just got released from the doctor last week.
Wow, that's great, though. Is he going to play football this coming fall?
Yes, he's going to play. And right now I have him working with a trainer to try to get him back strong and all that stuff now.
Ms. Thompson, talk a little bit about like Troy, and when you experience that loss of something due to your treatment, when he was younger, he got a portacath and he couldn't play when he was real young. And then as he got older, broke his hip due to a physical late effect probably. And then he couldn't play. How did that affect his overall self-esteem and his mood in general?
When I say he went from up here to down here. He went through, to me, it was like a depressed state. He knew he couldn't play the sport that he loves. He knew he had the injury, and I had to constantly keep talking to him. Troy, you got to get better. Once you get better, you'll be able to get back out there. But when you take away something that they really, really love, it's hurtful. So I had to continue to talk to him. I didn't want him to go into a state that he felt like he wasn't, he couldn't play what he wanted to play. So I didn't want him to start, getting into certain moves. So what I did do, and what really helped me out too, he has a good set of coaches. His coaches still allow him to still be with the team. Troy was on crutches. He still dressed out. They still allow him to go on away games. He still was with that team. He still was included with the team. And that is something alone that really, really helped him out, just being a part.
So when the old saying that it takes a village, it really does. When you experience a loss or you're going through something, it takes everybody, school, staff members, coaches, parents, neighbors, everybody kind of coming together. So it takes a village, so to speak.
Yes. And communication is the key. Just keep all the communication open. Let them know what's going on, what's his weaknesses, what's his, his strengths, and it really works out.
I'm glad you used that word communication too, because I often say, even though a lot of these children were diagnosed very, very young, and the research says, all 90% was the research we read the other day of these children who are now survivors experience late effects of their treatment. And so it's important to still each year educate the teachers on the diagnosis and the treatment and where your child has been. And because that's the only way that they'll be able to serve your child or recognize something in the classroom.
And what I also do, Ms. Morgan, is that might be helpful to the other parents as well. When they send those packets home, like at the beginning of the school year, to fill out for the child's information, their address, all that stuff, I always list Troy's medical condition. I always put it up. I always list it so they can be abreast of what's going on.
That's a good advice. And I think that school health plan is something too that you can always put it on that also.
Yes, I have it on it as well. Yes.
Mm-hmm. Well, thank you for sharing all that.
You're
and
welcome.
I'm glad he's going to play football this fall.
Yes,
And,
I'm trying to get him healthy, strong, and all that good stuff.
All right. So our next parent is Liz. And Liz, you are the mother of 3 beautiful girls.
Yes, I am.
And, Sophie being the youngest, she was diagnosed, you said, at 3 with acute lymphoblastic leukemia.
Yes, ma'am.
But what was some of the major challenges that Sophie faced when she first started school?
Well, her very first day of school, I was called halfway through and they kicked her out because the paperwork from MCV, it was so much for them and they had never seen anything like it that they couldn't understand if she was actually cleared to be there or not. So that was definitely something I could have used someone with more knowledge because it was a little bit traumatizing, although we, went to the movies, I think, after that. But other than
That's one of my first, Liz. I'll be honest with you. I've been at VCU 30 years. That's one of the first, and I know that she's the only one I know that's being sent home the first day.
It was wild, and it was hard to keep me calm. But we got through that. But other than that, I would say that her biggest struggles were fatigue in the middle of the day, way more tired than other kids, and she would just fall asleep. So I was pretty close with her teachers, and they would just let her put her head down, or she could go to the nurse because I knew the nurse pretty well, and they would let her take little breaks if she needed to. She was bullied because she was bald, and she was a girl and she had a bald head, so we had to bleach it and paint it pink so everybody knew she was a girl. Because she, the boys would pick on her on the playground, and so she's pretty spicy now. Nobody's going to pick on her ever again. But she also had some neurological delays, and she makes straight A's now. But in kindergarten and first grade, she really was interested. She missed preschool. The other two, had the joy of just coloring, learning all that stuff. And we were in the hospital. We got out of the hospital the day of Meet the Teacher for kindergarten. But it took her longer, and she knew it, but she just couldn't. It was just harder for her. Everything took longer. She felt like she didn't have enough time, and and it affected her grades and her attitude. But we got over it eventually.
I know, but tell how did you solve some of those problems
I stayed in close contact with every teacher that she had and the other kids, and they were pretty understanding. It's a huge difference, and as far as I knew, none of her teachers had ever had a kid that had cancer or went through chemo before, which I don't think that's going to be the case going forward.
So it was a learning curve for everybody.
Yeah. So and they really realized, they knew grown people who had been through cancer and treatment, and that's hard enough. And you got kids trying to learn, all the basics while they're, full of chemo and she was still on other medicines while she was going to school. So it affected, just about everything. But, teachers, they take the child development, so they have an understanding of that. And then on top of it, her teachers anyway, for the most part, they gave her all the extra time that they possibly could, and explained to other kids to mind their business. Why does she get to put her head down and go to sleep? Because they want to do it too. So for the most part, I think that it wasn't as traumatizing as it could have been, because it was traumatizing as it was just being bullied and being tired and feeling like you couldn't do what everyone else did. But with a little boost here and there, and not, it was hard, borderline. You don't want to make them feel like they're different or that they can't do something, but then you also have to single them out and, give them a little bit of special treatment. So it's an interesting balance to deal with.
You mentioned the special treatment. what kind of impact did the diagnosis have on her siblings?
I mean, they definitely felt left out. And sometimes when we would have a plan that they would be coming home on the bus, Sophie and I would be stuck at the hospital. So their plans would change all the time. Sometimes they didn't know who was picking them up or if they were spending the night with someone else because we were gone. So it was a fuzzy time where half the time I didn't even know where they were exactly until it was bedtime. So I sat them down and told them pretty much, things are weird with us now. So it's always going to be exciting and you need to be ready, for whatever happens. And I'm sure somebody's going to take you out to eat or let you do something I'm not going to let you do. So, I mean, outside of that, we were kind of separated for I don't know, a couple years on and off when Sophie was in treatment, because if I had to stay in the hospital with her, we didn't see our whole family. There's 5 of us. There was Sophie and I at the hospital maybe half the week, and then we'd come together and try and catch up with who was doing what. So it was kind of a separation.
Do you think, did you have to educate the teachers of the siblings as well?
I did. They were pretty understanding. What I would say to parents, mostly outside of the teachers, in the front office, the other mother was mentioning, putting down the diagnosis on all the paperwork when you get all that homework, when you fill them out at the first day of school. I would also suggest that you write down everyone that you've ever known and everyone in the whole wide world that you trust your kids with, because calling in to the office from the hospital and having to change plans where maybe they would take a bus home and you're not going to be home. Sometimes they were a little hard-headed in the office, and they would say, well, the policy is you have to fax it in or you have to write a letter, and you can't do that from the hospital. So it would be very helpful to cover those bases right off the bat while you're educating the teachers, and explain to everyone in the office, let the office know which kids may or may not have emergency situations in the hospital, so that they don't give you the business about what their policies are, because frankly, they don't matter when you're having an issue. You just need someone on the phone that can understand that you need to send them to another house on a different bus or to a daycare, have a plan B. I always had plan B and plan C, but there was always like sort of someone that wanted to, uphold the regulations when at that moment, it doesn't apply. So having them really understand who might at the drop of a hat have a situation is definitely something that would be helpful.
I'm hearing that communication as well as some flexibility in there.
Yes.
And that sometimes that sibling might come to school and not be prepared.
Right.
Sometimes the homework might not be completed.
Right. It might have been left in someone else's car, or who knows, because they're going everywhere that they possibly can to be taken care of while you're trying to, keep the other one alive.
Absolutely. Absolutely. Well, thank you for sharing all that, Liz. Thank you.
You're welcome.
Our next participant is Erin, and Erin is unique to our panel discussion because she's not only a parent, but she's also a teacher. And so, Erin, I'm just going to ask you, you've heard, you come to Survivorship, you hear all the information, you go to school, you work with teachers and school staff. What do you think is critical for parents to share with teachers and school staff when their child is transitioning back to school following treatment?
Well, Miss Alma, as a parent, first and foremost, when Landon was going through elementary school, I chose most of the time not to mention that he had been through cancer, because I didn't want him to be labeled, or I didn't want him to have special treatment. And unfortunately, that was not beneficial to Landon in the long run. So when I started to notice in the 5th grade that grades were starting to slip and the teachers were not dealing with it appropriately, I guess, that is when I reached out to you, Miss Morgan, and we decided to put something in place for Landon. So I know one of the other parents, Ms. Taylor, I believe, spoke about how important it is to communicate with the teacher, with the administrator, and really let them know what's going on, because there are a lot of things going on socially, emotionally, physically, cognitively, and knowing that, like my son's teachers, most of them did not know that. They're not able to better help him, and they're not able to make any kind of accommodations or interventions for him without knowing this information. So as an educator, I've been working in the same school for 13 years now, and we have only had one child come through the system that has had cancer. And she was 5. She is 5, I should say. She's 5. She's fine. But she was not in the school long enough. She didn't come back to the school. So we weren't able to make any kind of accommodations for her. But I know that we would not have been prepared, because the majority of us had not been trained on how to, accommodate a child with the kind of interventions that she might have needed. So definitely training and communication from the school as well, training the teachers and training, the principal and everyone what needs to be done when a child comes in after treatment, and the transitioning that they need.
How important do you think it is for a child, after hearing so much about the late effects of treatment, how important do you think it is for them to have an educational plan?
I think it's extremely important now. Like I said, I didn't want Landon to feel different than the other kids. But he is. I mean, that's just how it is. He is. And I've noticed a lot of things now that he's getting older. The ADHD, the awful handwriting, the inability to focus. He's also extremely short for his age, which causes a lot of bullying. He's extremely self-conscious about it. And just really without that 504 plan that we came up with, I don't think he would be as successful as he is right now, because he does get, breaks when he needs them. He's able to go to another classroom that has less students and a little bit quieter when he needs to be, to take an assessment, SOLs or any of the other assessments that they're given. And he just, it's helpful. It's just very helpful when they know what to expect and they know what the child is going through.
I often get calls, and I hear sometimes, and you mentioned the ADHD. So students, and they are late effects, attention and concentration sometimes, and anxiety, and being bullied, and as Troy's mom and Ms. Thompson and I were talking, if they feel a loss or if they don't feel their very best. And you mentioned that sometimes, him being smaller in stature, that, that has an effect on him. But we can put things that you said that, you really didn't want people to know, you didn't want them to be different. But I have found, and I'm sharing this because I want, the teachers that are listening to this panel to understand too, that, and other parents that might watch it, that it's sometimes parents say, I need some accommodations for my child, but you can't tell them that they had cancer at school. I can't do both. I can't ask for accommodations if I don't have a reason to tell them that we need the accommodations. So you have to tell. At the same time, I think it's important that we are all different. and that's what I tell our young people. And sometimes they say, I feel different, and people don't understand. We are all different, and we all have challenges, and we all have strengths. What are some positive approaches that were taken at school when Landon was having some problems, or that you said he's thriving now? What have been some positive approaches that have been put in place for him?
Well, when the teachers then found out about his diagnosis, they were, of course, a little bit more understanding, a little bit more compassionate. They had more patience with him. They seemed to give him a little bit more grace, because now they're realizing he's not just doing this because he doesn't want to do it. He's not just doing it because he's bad. He really can't help it. And this is why. And now that we're educating them about this, because the majority of people that are not in our shoes, they don't know. I didn't know before I had my son. I had no idea. And without being educated, it's easy to brush it off as a misbehavior or boredom. So I feel that it's important to have that communication, and that was something that increased greatly. And then from there, we started to roll and get a little bit more services for him. He was then getting help from the occupational therapist because of his handwriting was so awful. He was able to use the Chromebook for typing if it was easier for him. And one of his problems is he is super forgetful, and he is not the kind of kid that's going to write anything down to try and remember it. It's just not going to happen. And letting them know that, please let me as his mom know, because I'm going to sit there with him and I'm going to help him every night, because he's not going to do it. That was helpful as well. So they were very positive with all of the accommodations that they made. And it was just refreshing to know.
I think too, you said they were a little bit more lenient. And I'm not saying be more lenient, but everything has consequences, but sometimes if we can build in positive rewards rather than negative rewards.
Right.
Sometimes I'm called and, children are being put in the hallway because the teacher feels they're disruptive or they're missing recess, and when they really need to be outside running off the energy. So if we can look at more of a positive reward system rather than a negative, I definitely think that helps the child.
Absolutely.
Sometimes when children come back and they're talking to me, at clinic or whatever, and they're getting in trouble and they're, and everything is negative consequences. I've heard some of them say, I feel like I'm being punished for having cancer again. And we never want them to feel that way.
Absolutely.
So always share, and always say we have to brainstorm. So brainstorm with those teachers on, and the school team, most school-based teams, with the psychologist and the social worker and the administrator and the teachers and everybody together. You got a good team there to brainstorm with and talk about positively how we can approach it rather than with a negative consequence.
Absolutely. And I close with saying, never be afraid to advocate for your child, because sometimes in the school system, they're not getting what they should be getting. And it's important as a parent to know what they should be getting and know that they are getting it. So we are our biggest advocate for our kids.
Absolutely. Our next one is Miss Courtney there. And Courtney, you were diagnosed at the age of 15 with Hodgkin's, and you were a teenager and you were in high school. So we've heard mostly from parents today who their children were diagnosed younger. So as a teenager in high school, can you go back and remember what was your initial thought when you were diagnosed?
That I was going to lose my hair.
That was your first thought, I'm going to lose my hair?
Yes, I promise. And I asked every single doctor and surgeon that entered that room, are you sure I'm going to lose my hair?
Were you devastated?
I was at first. Yes. I mean, I know that sounds crazy. I know
No, it doesn't sound crazy.
But seriously, like my hair, I've finally grown it out like it was before. I think it was like this long. And that was definitely the most devastating things to me, because before I found out I was sick, I had never gotten a surgery done. I had never even had my blood drawn. Like, I only went to the doctor if I was like deathly ill, because I just didn't go. I wasn't the medicine or go to the doctor kind of person. Like, so up until then, I didn't know anything about any of it. So really,
were you worried about school or friends or your extracurricular activities?
Yes, I was. I wasn't involved in sports. I quit softball way before high school because that was not for me. But yes, I was in FFA. I was in prom committee. I was in beta. I was everything. I was a part of everything I could be. And that, my friends, was another really difficult thing, because I was a very outgoing teenager. I wanted to go, go, go. Like, I was always out with friends. I was always doing something. Like, everywhere I went, my friends were with me, and I had a lot of them. Because I will say, like, looking back, like, I'm an adult now, looking back, I was not just friends with one group of people. I was friends with everybody. And I do remember, like, having to call my friends and letting them know, and one of them specifically, she was my best friend. And I called her and she was like, Courtney, stop joking. Like, that's not funny. And I was like, I know it's not funny. Like, I'm not joking. So, she hung up and she came to the house, and my parents sat her down and explained it to her. But yeah, my friends were a big part of my concerns. But it worked out. Every single night, my yard was full of vehicles. I wasn't always able to be in front of them, but they'd sit outside my house and talk to me through the window. Like,
so that's the positive of letting people know.
Yeah.
Don't hide it. Let people know for support.
In this town, there is no hiding anything anyway. So there was no way we could have done that.
All right. Were your teachers understanding? Did you feel like your teachers had a good idea of what you were going through?
For the most part, I was very close with my principal, and she made it very known to all of my teachers. And I did not go to the school since the day that I was diagnosed. I did not go to school for 5 months. I was out. But my mom went up there and had a meeting with all of my teachers and the principal and the nurse. All of them sat in, and my mom explained what was going on. And my teachers, they acted like they were understanding, but I struggled with math. Mainly was never my strong suit. But when I was going through chemo, and I had a homebound teacher that would come like a couple days a week, and she'd come for a couple hours. And our math classes were computer based, and they would not allow me to bring the computer home. They would not allow the computer to come to me. So that was a whole part of my grade that I was getting incompletes for. And my principal fought it and fought it and fought it, and nothing ever became of it. And that she was so devastated, because she went to the school board, she talked to them, and nothing changed. Now I'm sure it's different. I'm positive that it is different because the kids every single day are bringing home a Chromebook now. So I didn't have that option, which I think would have helped me a lot. But my other teachers, they were very, very understanding. But math was not.
Well, I think a lot of that was because it's so multi-steps and everything relates. You have to learn one skill before you learn the next skill.
Right.
And you had so many gaps from missing school because of your treatment.
Right.
How did late effects play into transitioning back to school and your learning and all of that, Courtney?
So I didn't realize it at first. And honestly, my mom noticed it, but I did not start noticing my forgetfulness until recently. When I was in high school, I was like, Mom, like, I just forgot, like, whatever, but I really had a hard time remembering certain things and even simple things that I just forgot. Like, it just went out of my brain. I wouldn't say I had a hard time paying attention. It was more like I needed, like somebody said earlier, burst of energy, like the kid was acting up. But I just sat there, but I was like twiddling my thumbs, I was bouncing my feet, and I would just ask, like, can I step out? Can I please step out? And some of them would roll their eyes, and some of them would say, well, yeah, you can step out, but not for, more than 2 minutes or something. So I would go to the principal's office and I'd sit in there. Then they didn't come and get me. So
you had that attention and concentration issue a little bit.
A little bit, yes.
And you probably had the short-term memory loss a little bit.
Yes.
You told me in clinic the other week, you said, Alva, I really think I probably had the chemo brain going on. So
I do. I do. I have it now.
You have it now. Okay.
All this sudden stuff going on. I'm like, I write things down constantly because I do not want to forget.
Well, so you've learned to compensate for it as you've gotten older.
Yes.
Yeah. That's good, Courtney. That's great. And that's what I hope all of them learn to do. You have a big day coming up soon, and I know you're really, really excited. And you just got a new full-time job with benefits and insurance.
Yes.
And that's exciting because you were a little worried a couple of weeks ago in Survivorship Clinic about, I need a full-time job, Alma. So, and then now you have that. So it's looking like everything is just falling in place.
Yes.
So I have to ask you, does the diagnosis of childhood cancer seem like a million years ago, or is it still just fresh in your mind?
It feels like it was forever ago because my life is back to normal now. And I don't, when I was in high school, I do feel like I had special treatment. And when I was in high school, I liked that because I didn't want to sit in class all the time. And I was a teenager. But now nobody knows that I had it unless I tell them. And it's a good thing for me now because I'm not looked at a certain way. But I will say this is the hardest thing. For a long time, and my dad was like this too. Why me? Why us? Why our family? Why did we get this? But why not though? Really, I am thankful every day for what I went through because it made me who I am, and I love who I am. So as an adult, like right now, I'm gonna cry. I'm sorry. Right now,
I'm gonna cry with you, girl. I'm so proud of you. I'm proud that you can share this with us. We have one more participant.
Okay.
And this is Nancy. Hey, how are you? Vasquez, the mother of Stephanie. And Stephanie was diagnosed at 4 years of age, Nancy?
Yes, ma'am.
With leukemia.
Yes.
And I put her, I asked her to be a part of our panel discussion. And Stephanie, I see you in the background there too. Hi, Stephanie. How are you?
Great.
You've grown up since you were 4 years old, first diagnosed.
Yes.
But Nancy, I would love for you to discuss some of the challenges Stephanie has experienced in the school setting due to her diagnosis and the late effects of treatment.
Yes. So, this Stephanie, when she had a diagnostic, so it's very, very hard because it's a little one, 4 years old, and you know, I am Hispanic, so I think so everything is different. So when you don't have more family, or when you stay only alone in the one country, you're feeling very hard, very, 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 very sad, very everything, because it's my first child. So a diagnostic at the 4 years old, I'm feeling very, very bad.
So you felt all alone almost, being in a new country, having your first child. She's diagnosed with leukemia, and you probably didn't know where to turn, really, did you, Nancy?
Yes, and not have the family stay with you when nobody helped you, or nobody we say, don't worry about it, everything is fine. So because I live here in Virginia, but my mom living in California, my grandma and my aunt living in Guatemala. So he stay alone here only with my husband. So yes, very, very difficult.
Well, I know over the years, I went to many school meetings with you.
Yes, thank you, Ms. Selma.
Can you talk a little bit about, you speak Spanish in the home.
Yes.
But Stephanie's in a general education program at school.
Yes, but she is
speaking both. How difficult has it been to help her with her homework and her studying and her tests?
Me or Stephanie?
Well, both, because if she comes home and has homework, and sometimes children need help with their homework, was it difficult to help her, Nancy?
Yes, sometimes it's very difficult because the school give you the papers or homeworks, and when in the Spanish language no show me, so we need to dictionary, or we need somebody explain to her or help her about the homeworks, como algebra or whatever. It's more difficult. Yeah.
So when the papers came home, they were in English, and you really, living in a rural area, you really didn't have anybody to interpret for you. Is that correct?
Yes.
What support at school could have been more helpful for you?
For me,
the school board,
nobody, because the first one, sometimes when asked at the teachers, we say, I can help you here in the school, but I can explain to you, but you can show you in home. It's very, very difficult. So for that one, sometimes I call you when I have the meetings in the school, when I have the meeting for AIP last year. So when all the school is, for a school and computer. So yeah, you don't have nobody we can help to you, or she tell me, oh, mommy, look, I have the homework. So this is the difficult time. Yeah.
Now, I know that Ask does have online tutoring. Did you ever get any online tutoring through the Ask with Miss Erica?
No.
Is that because of the internet? Do you have trouble getting internet services where you've lived?
Yes, because I live in outside the country, the city. So yeah, we have the big problems because you're calling all companies. The companies that tell you, no, I not can bring to you the service because you're not living in the city. So
I see, we're wiping our eyes and we're laughing at some things and crying at others. But at the same time, I know when our audience, our participants, they see this panel discussion, I know they're going to be touched. I know they're going to remember what you told them about, the late effects and the story the story that you told about your child being diagnosed, losing the ability to walk and talk and having to learn those skills over, being bullied in school for the short stature and the physical late effects of treatment, how the siblings sometimes wonder who's going to pick me up and where am I going to sleep tonight, and the loss that comes with it of not being able to play football and not being able to go to your prom, just the different things that happen along the way. But you have to keep having a positive attitude and just moving forward. We will close our panel discussion. Thank each and every one of you for sharing your stories and being a part of this. You're going to make an impact on a lot of people, and thank you very, very much.
Thanks for having us.
Thank you.
Thank you. Welcome, Ms. Morgan. Thank you.
Absolutely. Thank each of you.
Thank you so much for joining us today. Thank you to all of our presenters for sharing their expertise and time with us. We hope that you come away with a greater understanding of the childhood cancer experience and the very important role that school personnel play in making sure that childhood cancer patients, survivors, and siblings get the educational support that they need. It takes a village, it really does, and thank you for partnering with us. Please remember to complete the pre and post surveys. I know we've said it a lot, but we need both the pre and the post surveys from you in order to distribute your CEU or CNE certificates. Those will be emailed out next week. A recording of this conference will be available until April 30th. So if you found it helpful, if you have colleagues you think would enjoy it, they can register until April 30th. And get their credits as well. So please share. We hope that you found it very informative and helpful. Ask Childhood Cancer Foundation can continue to be a support for you. So as you go back to your schools and you implement some of the tools and ideas and information that you learned today and you have questions that come up, please contact us. We can be found on the web at askccf.org. This concludes our 2022 Ask Educators Conference. Thank you for being a champion for kids with cancer.